Welcome, everybody. Thanks for being here in person, and we've got a good number of folks online, so appreciate you all taking a Friday morning and early afternoon to join us for this today. I'm going to start off with reading our CME statement. Today, let's see, our title is Beyond Weight, Optimizing Surgical Success Through Strength and Health. Let's see, objectives. Our objectives are to describe challenges and solutions regarding exercise prescription and adherence for underserved patients, including those from rural areas. And we're going to describe mindful eating for optimal health. An objective is to describe mindful eating for that's in there twice. Describe key concepts and current research on weight-inclusive care, including the negative health impacts of weight stigma. You will discuss the increased risks of sarcopenia and osteoporosis associated with weight loss, particularly when induced by pharmacological or GLP-1 medications or surgical interventions. And our final objective is to identify exercise-based strategies to preserve and enhance lean muscle mass, bone density, and metabolic health while addressing challenges specific to individuals and larger bodies. So these are the requirements for qualification of CME credit: attendance for a minimum of 30 minutes, must sign the evaluation form. RNs and allied health professionals need to add their loss and ID number. Also, new participants are to indicate their mailing address. Let's see here. So this workshop is sponsored by the Arizona Biomedical Research Center in collaboration with Northern Arizona University's Center for Community Health Engagement Research. And then let's see. The following planners, faculty, or other individuals in control of content for this educational activity have relevant financial relationships with ineligible companies. None. All of the relevant financial relationships listed for these individuals have been mitigated. None of the remaining planners, faculty, or other individuals in control of content for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Arizona Medical Association through the joint ownership of Northern Arizona Healthcare and Northern Arizona University. Northern Arizona Healthcare is accredited by the ARMA to provide continuing medical education for physicians. Northern Arizona Healthcare designates this live activity for a maximum of 4 AMA PRA Category 1 credits. Physicians should only claim credit commensurate with the extent of their participation in the activity. Okay, so we got that covered. Once again, welcome. Okay, so welcome to the final of our 5 forums that we put on this year. This one is Beyond BMI Part 2, a weight-inclusive approach to optimizing surgical and health outcomes. My name's Steve Palmer, and I'm a professor in health sciences at Northern Arizona University, and I'm fortunate to work with so many brilliant and dedicated people who are making this region a healthier place for all. This forum is primarily supported by the Arizona Biomedical Research Center through the Department of Health Services. So thank you to John Garcia and Keelan McCool for their support, and I believe they are online. Also, thanks to the Center for Community Health and Engaged Research Center for their efforts to address health disparities and improve the health of people from all communities. So let's see here. Moving on to slide 2. Once we get that, I'll talk through it. With the support of the ABRC, we make 4 other workshops. We've made 4 other workshops or conferences available this year. On February 28th, we examined efforts to coordinate services for individuals struggling with addiction. Dr. Jen Kahn, who's the CEO of Flagstaff Medical Services, spearheaded organizing that workshop that included services provided from Crossroads, from Flagstaff's The Guidance Center, Northern Arizona Health, and other agencies. In January, our first workshop of the year was actually led by Pam Buzzard from NAU's Klein Library. And we examine opportunities for research using the All of Us data initiative. And all of these materials for all our workshops are available online, and you'll see a link or QR code to that link at the end of the workshop. Let's see, on March 28th, Dr. Joe Mihalacek brought together tremendous scholars to present research and opportunities using spatial epidemiological modeling for disease modeling and public health. And then April 14th and 15th, we went to Yuma for the 7th annual forum on border and rural healthcare. And that was spearheaded by the esteemed Amanda Geary, past state senator, and the Regional Center for Border Health. And then today, we're looking beyond BMI to focus on weight-inclusive approaches to optimizing surgical health and outcomes. Dr. Karen Mueller, Kathy Stucker, James McCallum from NAU Physical Therapy, along with Lori Perlmutter and Brian Kinslow, have all, I mentioned Kathy Stucker, have taken the lead in planning and bringing providers and scholars to share research and best practices for improving surgical outcomes. So thank you all for your work on that. Let me get down my next notes here. I'd like to introduce Cindy Beckett, soon to be retired director of the Evidence-Based Practice Credentialing Program of the National Institutes for Evidence-Based Practice and faculty at The Ohio State University. And we're going to go through and we kind of put together a little overview of some of the research that has led to this workshop. So just to frame it, last year we started with Beyond BMI. Dr. Don Clifford from NAU Health Sciences brought together tremendous speakers, many of whom are here again today. Abby Chan, we had Jeff Hunger, we had Brian Kinslow last year. And one of the things that came up was the need to focus on exercise rather than weight loss for improved surgical outcomes. And that's where the idea came from. So thanks, Brian, for bringing that up. And so that's today. So I'm going to turn it over to Cindy.
So good morning to everyone online and here. Just kind of, we're all aware of the issues around obesity and weight loss cycling, where people are always seems like they're doing dieting or something. So our presentation today, we're going to be looking at the issue of obesity, but we're also going to be talking about ways to help our patients to get ready for surgery. Traditionally, it was like you'd go to the doctor's office and they say, okay, you need to lose 15 pounds before your surgery. Good luck, go. But now we're starting to see more pharmacologic intervention, as in with our GLP-1s. So we're going to talk about those today, as well as other strategies. But our goal is to help people get to an optimum weight that's good for them. And as you'll see on the slide, and I know you probably can't read the detail, but these are the different types of GLP-1s, the semaglutides, the retaglutides. But notice we have at the bottom, it says body weight change is in green. Lean body mass change is in red. We don't want to lose lean body mass. We want to lose fat. We want to help people optimize their weight. So what we're going to be sharing with you today is kind of some of the complications that can happen, but also some of the things that can be very helpful with this process. So we all know about obesity and people that are overweight, huge risk factors for health-related issues, from type 1 or type 2 diabetes, cancers, all types of cancers, cardiovascular disease, asthma, gallbladder disease. So it's the largest growing modifiable risk issue in the country. It's definitely a pandemic because we're fat everywhere, but US holds I think the key for the largest percentage of people that are overweight. It causes all kinds of disease risks. So just knowing that as healthcare providers and support personnel, it's important that we help to, again, optimize our patients' health and well-being before they go into a procedure. Focusing just on weight loss is failed. I mean, we've seen it over and over in the evidence that just by saying you need to lose weight or go on a diet, it doesn't work. People may lose a few pounds and then they gain even more. The yo-yo effect has huge, devastating complications, especially on the cardiovascular system. So when we're working with patients that need to lose weight, we need to think in terms of not just telling them, okay, you got to lose a few pounds. It's more the management of weight and helping us prevent those additional risks and diseases. You can't ignore adiposity and health. Lower body weight can help improve arthritis, cardiovascular health, help prevent cancer, have much more positive outcomes. and helps us get rid of some of that excessive tissue. Surgical outcomes, there's odds of developing infections, venous thrombosis, renal complications. There's no elevated odds post to help prevent those post-op complications, increased risk of mortality, morbidity, pulmonary complications, urinary tract, cardiac bleeding, and so forth. Huge risk for readmission. So just by dealing with the fat is not enough in this process. And so that's part of our discussion today. Miracle drug, GLP-1s, we see it on the probably every other commercial these days, or on the different brands that you can take, the huge advantages that these can have. For diabetics, they have made a huge difference for A1Cs, and they can be very effective. But we're seeing people that are not diabetics also using the GLP-1s. There can be a lean body mass loss of 40 to 60% of the weight loss. That's huge. It can affect skeletal issues, bone loss, increased fracture risks. And those of you that are like me, that are older, that would be, you don't want to be an older person and have those issues. Sarcopenia is a better predictor of complications from surgery than BMI. Again, lean muscle mass and sarcopenia are associated with surgical complications. GLP-1s are also associated with increased, the reduction of are not associated, with cardiovascular events. And you would think it would be a protector, but it really has not shown to decrease the risk of cardiovascular incidents. But loss of muscle and bone, as well as anemia, can compromise the physical function, metabolic rates, overall health in older adults. So it's not the perfect miracle. Believe it or not, many people on GPL-1s are malnourished because you don't want to eat. It's a great appetite suppressant. Yeah. People just, it's like, oh, I don't want to eat anything. So they may be malnourished if they're not eating a balanced diet along with the GPL-1s. Research examines that it's not the total caloric intake, but it's the diet composition. So it's what you're eating, not how much you're eating. Again, malnutrition is a problem. Another issue is gastric emptying, because it messes with your GI tract. Nausea, vomiting are big complications with this. So people are less likely to eat if they don't feel like they're wanting to eat. But it slows the GI system. So if you're going into surgery, you may have a greater risk of aspiration, because if you say, okay, we're going to have you NPO for 8 hours, 12 hours before surgery, it may take even longer than that for the gut to clear. So there may be a need to do clear liquids for a couple of days before you go NPO. Malnutrition, again, is a big issue. So looking at ideally, we're wanting to reduce fat. We're wanting these GPL-1s can be a great addition to someone to help them lose these information, but we want to make sure that we're not causing malnutrition. We're not causing them to end up sicker than we started with, and then we want to preserve muscle mass. So countermeasures to help with those GPL-1s is have a high protein resistance training and counseling to help with this process. So overall, it's having a plan, meeting with nutrition, seeing a dietitian, helping them identify what to eat and how to eat, so that the foods that they are taking in are quality foods. Additional protein is needed in the diet, and also a regime of resistance training, strength training, to help them minimize any lean muscle mass. So we've got some great opportunities to help individuals, and that's going to be the discussion today in our workshop. And one thing that I came across was having a health and well-being coach. And I love that concept, because it's somebody that can say, okay, we're here to help you get ready for your surgery. And in doing so, we're going to have you work with PT. We're going to have you work with nutrition. And together, we're going to get you in that best, most optimum condition prior to your surgery. That's a different message than go lose 10, 15 pounds before your surgery. So I think we have a great opportunity. And, body weight is kind of like the canary in the coal mine. It's going to be out there. and perioperative care and beyond is important. And what we're doing is trying to help these individuals have a positive experience preoperatively so that they can have a positive outcome from post-surgical. And we really need to focus on that preoperative care and identify those strategies that can be most effective. So today, we're going to talk about some of those, but lifestyle change is really most sustainable in this process. So we have lots of references. There's some really good literature out there. So these are available to you all. And I think it's going to be a great conference or workshop today. Anything you want to add?
Yeah, I just want to kind of reiterate once again, there's the association between adiposity and health risk factors, but the literature isn't exactly clear on any causality, right? And so that research is yet to come. However, we do know, once again, focusing on weight loss is a failed approach. So what we really want to do is focus on throughout surgery and beyond. And as we were talking last night at dinner, it is really more about the psychology of behavior change, making sure people are just being healthy and making sustainable, healthy choices in the long run, and rather than focusing on weight, even though it's not, as what we talked about last night, is not a sexy approach as saying, hey, come lose the weight. No, that's not going to get you anywhere. So let's focus on those things that are sustainable and can lead to better operative outcomes. So thank you, Cindy. I'd like to introduce Dr. Karen Mueller. So Karen has worked in academia since 1987. And is faculty at NAU's physical therapy program. She's author of the text Communication from the Inside Out, Strategies for the Engaged Professional. She's a member of the American College of Lifestyle Medicine and the American Physical Therapy Association, Health Promotion and Wellness Council, and has served the APTA in a variety of roles, including chair of the Oncology Academy Hospice and Palliative Care Special Interest Group and the Oncology Academy Executive Board. In 2021, she became a national board certified health and wellness coach. So she's conducted research in physical therapy, student well-being, moral reasoning, and professional identity formation. And she's also soon to be retired. Congratulations, Karen. And thank you for helping with today, as well as your contributions to PT and higher education.
Thank you for that wonderful introduction. And it is my pleasure to introduce our next speaker. We are going to talk about an inclusive approach to nutrition. And so I am happy to introduce Abby Chan, and she is a member of the Flagstaff-based weight inclusive registered dietitian who specializes in sports nutrition, eating disorders, and helping her clients reestablish their relationship to food and movement to find more peace in their relationship with food and their bodies. Abby earned her master's in nutrition and dietetics from Arizona State University, and she is now the co-owner of Evolve Flagstaff, an integrative practice that focuses on nutrition therapy, physical therapy, intervention, injury prevention and rehabilitation, and strength training to help her do what you love for life. She is also an avid runner, cyclist, aerialist, and community organizer. So, Abby, it's really a pleasure to have you. Welcome.
Okay, so thanks for that introduction. My name is Abby Chan. I'm a registered dietitian, and I specialize in working in weight inclusive care. And so I'm not just going to be talking about nutrition today. I'm going to be giving an overview. If you happen to not be here last year, there was a kind of a rock star, actually, group of speakers who were here, some of the leading researchers in weight inclusive care. And it was phenomenal. And so I wanted to kind of set the scene for today to discuss really the ins and outs of what does weight inclusive care mean? How do we start to really implement this so that we are reducing bias and reducing risk and reducing harm? So first and foremost, I want to extend an invitation. And this invitation is first and foremost that this conversation is likely going to be uncomfortable. And I hope that it is. And I hope it's uncomfortable because these are going to be the things that go against a lot of the education that we have been taught in our weight-based and very weight-centric education model. I want you to also understand that if this is uncomfortable for you, I want you to ask the question of why is this uncomfortable? Why is this bringing up a feeling and sensation in me? And what are also some of my biases when I'm looking at when I'm actually starting to feel these things, and what's coming up in this feeling? And one thing is that I also want to invite a lot of question. I'm happy to have this discussion. I don't get to just stand up here and just talk at you. So I hope that this does get to be a conversation. And I want to first and foremost also note that every single person who's under our care, who that we are in community with, our friends, our family, they have the right to bodily autonomy. That means that we do not get to dictate their health. We do not get to tell them what they need to do. And especially if they are not coming to us for a specific cause or a reason, we don't get to discriminate. Any questions on that? Great. I have no financial disclosures, and I do have some privileges of disclosures, which I'm going to talk about in a second. But I will be using today the terms obesity, fat, overweight, and also discussing some of the obesity epidemic. Does anyone know why I put these in air quotes? Because these exact words are inherently stigmatizing. They are inherently classifying someone and defining their worth based on their size. This is why they're in air quotes. This is why I do not use them actually in my practice. Some people will reclaim the word fat, and that's why that one's actually not in air quotes, because just like tall or short or someone who has small feet versus big feet, it can be a descriptor, but that is also that person's choice. I will also be discussing eating disorders and disordered eating and the prevalence of these, especially when we're talking about the group of individuals who are quote unquote obese. I will not be discussing the extensive history of BMI. I'll give a brief overview, but I would like to be clear that that could be an entire semester presentation. All of this could be actually multiple semesters of content. So I will try to get through it in a timely manner. And I will also not be going in depth on bariatric surgery. I will not be discussing weight loss medications. I will have a few notes on them, but I am not, first and foremost, a prescriber. I know a lot about them, but I'm not in charge of prescribing them. I deal with people every single day who are on them. And there's a lot of just nuance to them, right? And so I think we're also in a place where we are still trying to understand them, especially on this huge global population. We are currently running a mass population-based study right now. And so we'll just end up seeing what the outcomes are. And so first and foremost of the content, I'll be exploring the cultural and educational roots of weight bias and weight stigma. We will then start to examine the psychological, emotional, and physiological consequences of weight stigma and weight bias on individuals' health. We will also review the current evidence supporting the outcomes and advantages of a weight-inclusive care model, and also some clinical approaches that you can actually take from today to start implementing into your practice, into your community, and into your lives. So I want to first and foremost discuss what is diet, beauty, and wellness culture. This is something that has been around for a long time. We kind of now have a word and a term for it, although it's the ever shapeshifter. Dieting, we know, is not cool. It's not cool anymore, but wellness is really sexy right now, right? And so I want to just discuss what this means. So it is the societal belief system that upholds the thin ideal and directly correlates body size with shape, health, morality, as well as self-discipline. It is a culture that promises a narrow standard of beauty while stigmatizing those who don't conform to the ideals. It perpetuates a culture of consumerism, ageism, racism, ableism. I will also add here colonialism, and propagates misconceptions about food and exercise. All the while, we ignore the role that genetics, trauma, systemic oppression, and the social determinants of health have on human health. And this is something to where I want to just take a moment, and if you can even just close your eyes, or even not even close your eyes, but just think about, where have I seen this recently? Where does this show up in your life? This aspect of, here's this one thing that's going to fix you. This aspect of, do this like 10-step facial routine. Like, anyone have some place that they've come across that recently? Yeah. Anyone have a specific example they want to share? Oh, targeted ads on. Some of them are really fun. Ashley was just telling me about some really fun earrings, which I adore. I love some of it. Most of it you can totally miss me with. And so this is huge. This is ingrained in our society. It's been in our cultural context for a long time. We've long, before we even started categorizing like actual names or labels when it comes to BMI and things like that. This has been around in the classification body since the beginning of time, specifically going all the way back to enslavement. So this is not new. Yes. Oh, influencers on social media. I just got stuck in a really gnarly hole last night. I'm not even going to give it any airtime right now. It was disturbing. You all want to talk about that later with me? Totally can. Yes. So I think influencers now, again, there's anyone. So as even a dietitian, we are registered dietitians. Anyone can be a nutritionist. My dog, she could be a nutritionist. She's like tiny. She doesn't like eating. She shouldn't be a nutritionist. So it is not a registered term. So I would definitely be clear anytime you are getting specifically nutrition information, like look at the credentials. They actually do matter. So my privileges, I'm going to discuss thin privilege. So thin privilege is when you, let's see, let me back up. Privilege is when you don't think something is a problem because it doesn't directly affect you, right? I have never, outside of being an ally in this community, previously to that, in my younger years, I have created harm, I'm sure, but also I had never thought about, oh, what would it be like to get on an airplane? What would it be like to squeeze through this aisle here if I didn't exist in my body, right? Mm-hmm. So what does it mean in your everyday life? And that means that things are made more difficult because of the size of your body, just like racism, just like sexism, just like gender, all of these things. We know, hopefully, that racism isn't great, right? It's not nice. It's not ethical. We shouldn't do it. It is not a part of our hopeful current practice. The thing is that discriminating someone based on their size is completely legal, except for in Michigan State and New York City. Those are the only two places. And so thin privilege grants you access to, first, respectful healthcare. I can walk into my doctor and say, hey, my knee hurts or my hip hurts, and they're not going to tell me to go lose weight, right? There's actually data on people getting higher wages, specifically those who are in either a higher education. So they have, if you have a master's degree or even higher and you are existing in a fat or large body, you get paid less than your peers. What does that do with their overall health outcomes, right? Seating in public. I, again, have thin privilege, so I can comfortably sit in a medical facility. Gowns fit me. Blood pressure cuffs, those fit me. And I am also well accepted and also respected in a fitness community. Someone is not coming up to me and judging me based on my size. They're not basing my ability on that. And I want to be very clear that I am centering this around me, but this is something that is not accessible to everyone. Also, I have accurate portrayal in the media. And so when we're looking at the harms of this is huge. And I want to be very clear that thin privilege does not mean that you like your body. Okay? Doesn't mean that you don't want to change it. Doesn't mean that you actually think you are thin. It just means that if you can fit in these chairs comfortably, then you might fit in that realm. And so the harms of this is that increased fear of gaining weight across the size spectrum. That's going to lead to higher rates of eating disorders and disordered eating. And we will also have more aspects of dissatisfaction, not just for those who are in fat or large bodies, but for those who are also so fearful of ever being discriminated in that way. There's also going to be decreased access to care for fat and thin bodies. I'm going to go deeply into that today. And this will also promote excessive exercise and also exercise either what we call now addiction or dependence. Anyone have any questions on thin privilege? Has anyone ever heard of this before? Okay, cool. We got some dietitians here. Thanks, Brett. So that is one of my biggest disclosures, especially as I'm giving this information. I am not someone who, as someone who's speaking on all of these terms, again, I want to be very clear that I have never experienced, I don't have lived experience with this, but I sit across people every single day who do, and I see the harms of it. So I want to just do a real quick thing on defining bias. So there's a whole variety of different aspects and ways that we'll be talking about this today, but weight bias is the negative attitudes and beliefs towards and about other people because of their weight or size. Then when we start to shift towards weight stigma, this is the social devaluation and denigration of individuals because of their weight. This includes societal perceptions, assumptions, stereotypes, as well as judgments. And these are the things that are experienced by those who exist in a larger body. When we look at the internalized weight stigma, this is also where it kind of the mirror gets shifted a little bit. This also does not mean that you have to exist in a fat or a large body or be in a quote unquote higher BMI category to have internalized weight stigma. This is where an individual will absorb all of these cultural messaging, all of the systems that we are a part of within public health, within rhetoric we hear online around health. And this is where people will absorb these and then start to turn these negative messages about their bodies that they hear everywhere, every day from the moment that they're born into this world and start to apply them to themselves. Weight-based discrimination is the unfair and inequitable treatment of individuals based on their weight in areas like employment, education, healthcare, we've talked about that. And then also anti-fat bias is a term that was originally created by Aubrey Gordon. She is an author and a journalist and also a fat activist, and is a more direct and I would say even just very inclusive term of all of these in the sense of the aggressive way that weight bias actively devalues and pathologizes fat bodies. So this is the aspect of it. It's including internalized weight stigma because that's harmful. It's also including the overall systems that are a part of this, and also starts to go into that weight-based discrimination. So other terms that I think are really prevalent to today is looking at the bias in data or the surveillance or detection bias. So this occurs when a group of people is monitored more closely and frequently than others. This leads to an increased likelihood of medical attention or observation, resulting in higher detection rates of health conditions rather than actual increase in the condition's occurrence. Real life example is I have had to go to bat with medical providers for people who are, say, they're in their 40s, 50s, and have never had an A1C pulled, right? This is a common thing everyone should be checking, right? We should have a baseline, but it is not uncommon that I will, for someone who's in a straight size body, which that means a thinner body, who's not existing in one of the larger BMI categories. And so what that actually means is that for people, I have to go to bat to them and be like, hey, we need this. And recently I had someone who came up as type 2 diabetic and had no idea and existing in a thin body. We could have caught this earlier, right? And it's because we have surveillance bias and detection bias because as medical providers, we think and are assuming that these people, that anyone who walks in their door who looks healthy is fine. When we see this on a data proportion, this is going to skew our research. This is going to make certain populations look disproportionately healthy because we're not screening, right? It's also going to reinforce harmful stereotypes and assumptions that body size alone will predict disease. And this will lead to over-treatment in some and also under-treatment in others. Then we need to look at personal bias and anecdotal and confirmation bias. So they're a little bit different, but I kind of included them together. And so this is when an argument or position is backed by personal experiences or using a single example as opposed to robust evidence. So one thing would be, exampling is that, well, as a provider, I had a patient who lost 50 pounds once, they're doing great. That is one person, right? And do you actually know? Do you still see them? I have no idea. And so what this does, this is going to ignore the overall population data. This is also going to take that one very, very maybe special snowflake for that period of time. And you are going to then start to apply that to your entire population and care population. So this type of thinking overall, I think first and foremost, is that it's going to block curiosity. And when we don't have curiosity and we don't have an open mind when we are treating and working with individuals, we are also going to be blocking critical thinking, right?
Saying as clinical providers, I think there's a bias based on who comes back. So you think, oh, I don't stigmatize anybody. I see people who lose weight and reverse diabetes, but you don't see the people who are stigmatized because they don't come back. And so I think that can bias what we see. And I think it's easy to forget that when you're busy patient after patient.
Exactly. Thank you for that, Dr. Bray. And and I think that's a huge thing, right? And so first and foremost, we'll talk about like delays in care and lack of access to care and all of this later. But that's one of the main things is that we may not see someone who's actually, again, who may not be following up either because they felt really bad because the way that we made them feel. They were discriminated against, right? They're like, you know, that provider, they just told me that like, I just need to lose weight, or they praised me so much for the weight loss that I had, which tells me that previously I was bad.
Oh, interesting.
Right? So when we are commenting on bodies, when we are praising certain things, when we are praising things like aesthetics and things like that, this harms everyone. And it doesn't just harm you, even if you're getting like positive reinforcement, right? Because if I get a lot of positive reinforcement and then sometime I'm not, I'm like, well, what's wrong with me? When nothing. So that's a whole different conversation, why we don't comment on bodies, but whatever, I'm here. So I want to talk about the sources of stigma. So I want to be clear, first and foremost, that stigma does not discriminate. So this can happen across the size spectrum. This is from actually a 2006 study, so by Poole, and it was very early on, but it's looking at the sources of interpersonal weight stigma. And when we see the purple versus the blue, the purple is women who were surveyed, and then the blue was men. I think a lot of times people think that women get a lot of this brunt of you're not skinny enough, you're not thin enough, da, 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 da. But I want to be very clear that men are also suffering from discrimination and bias. And I would also say specifically now, we start to see again a lot of conversation around women with eating disorders and disordered eating, but especially in the rise of social media and in the rise of hypermasculinity and the rise of being super bulked and cut. I have so much more teenage boys sitting in my office right now in tears because they don't look like that. Wow. So I hope that's surprising to you, and I hope that actually strikes something in you. So the most frequent sources of weight bias and stigma are physicians and family members, right? So the people who are supposed to be taking care of us and love us the most. And I think a lot of it, because of our society, is so based in, well, you know, being thin is healthy, eat your vegetables, all these things, that we are missing the point here. And we are actually causing harm to the people that we love the most and the people who are actually underneath their care and who are coming to us to be professionals. So I want to just give a brief overview. That was all biased. I want to give a brief overview of the care models, because we currently mostly work in a weight-centric care model. That is where education comes from, typically. A few educators in here are doing a really fantastic job to change that for nutrition. Dawn and Ashley, thank you, and Caitlin. And to start to move and shift away from this weight-centric care model. So what this means is this focuses on weight loss as a primary goal for improving health. Second, often uses BMI or weight as a key indicator of health status. We'll talk more about BMI in a second. And it also assumes that a lower weight automatically means better health. When in my world, if someone comes in and drastically loses weight, I'm wondering what's wrong? What happened? And it's also common in traditional medical models as well as public health models. When we look at weight neutral care, which is what I'm talking about today, this is focusing on overall health behaviors. Weight, first and foremost, is not a behavior. I can't walk out of here and not do that. I can walk out of here and go drink some water. That's what I can do, but I can't go out and just change my weight. So this is going to be nutrition, movement, sleep, stress, rather than body weight. This is also going to recognize that health can improve without weight loss drastically. And it's also going to emphasize body respect, bodily autonomy, inclusivity, and reducing the harm that weight stigma and even the terms of using obesity or fat or severe obesity creates. Okay, so how do we get here? In 1930, Adolf Quetelet first started and created a mathematical equation to study the average man in his very, very, very tiny Dutch community. Am I Dutch? No. Am I male? No. Does this apply to me? No. He also specifically said it was never intended to be used for individual health assessment. Then we're going to bump it up, hyperspeed up to 1972. There's a lot that happens in between here. We don't have time. There's a lot that happened before here. We don't have time for that. Again, this goes way back to the times of Aristotle, Socrates, enslavement, of the categorization of bodies. But then, and if you want more on that, Sabrina Strings, you can write this down, phenomenal book on the history of the classification of bodies and stigmatization of bodies. In 1985, the NIH and the CDC, Ansel Keys, a very famous researcher, did a lot of things that we would never be able to recreate today. One of the most famous ones was the Minnesota starvation study, where basically he put people on what we would now see as kind of a normal diet. It's about 1,800 calories, something like that. And he looked at what happened mentally and emotionally in the long run, and it wasn't great. That's the whole thing. You should write that down too. Look that up later because it's fascinating. He rebranded this to the BMI and advocated for this as a tool to estimate body fat within a population. Also emphasized it shouldn't be used on an individual level. What do we do now? If anyone works in the healthcare system, what's the thing that pops up on your chart?
Oh, yeah.
Yeah, as an individual health marker. Great. So then we're going to bump up to 1985. This is when the NIH and the CDC adopt BMI categories to define overweight and obesity, making BMI a clinical tool in U.S. healthcare. This then started to really start to shift the way that medical insurance and policies were set into place, because if we could just lump people together, we can make a lot of wild assumptions, right? So then in 1998, the NIH updated the guidelines and effectively lowered them overnight, which made millions of Americans automatically just overweight. Did they do anything? No. If we are adjusting categories the way we're looking at things, is that fair? Right. So when we actually start to look at, and we've all seen them, the charts of, oh my gosh, the rates of obesity in America over time, there's actually a pretty big jump there. The reason why is because they changed the metrics. So now in 2023, the American Medical Association actually came out because there was a huge group of medical students from Michigan State who went to the American Medical Association and said, yo, this is problematic, what we're doing here, and we need to fix this. So effectively what that did was the AMA came out with this statement saying that you're right. This was never meant to be used as an individual marker. This is incredibly racist. This is incredibly biased. And we cannot apply this one formula, again, for Dutch men within an average age to the rest of the world, right? There's issues and kind of now what they're coming up with. There's aspects of looking at preclinical obesity versus clinical obesity. What that means is that preclinical means that, hey, you're actually really healthy. There's nothing wrong with you. You just exist in a body that we don't like to see. And then there's clinical obesity where it's like, hey, you got some health markers and some things we probably need to treat here. Oh, and by the way, you're also existing in a body that we don't like to see. That's what that means. So, big reflection question. We all hold biases. These are shaped by our culture, our upbringing, our education, our own personal experiences. These are normal. You're not a bad person. But after this information that I'm giving you, I hope that it actually allows you to understand of how can I maybe not continue to perpetuate harm. So the question is, how might your assumptions or beliefs about body shape or size influence the way that you perceive or interact with others in a positive or negative way? Right?
Are we supposed to tell
You, if you have an answer, you totally can.
Hit the button. Yeah.
One where it says push. I was just thinking about this because I started as a dancer. That was my first degree. And we used to make a lot of judgments when we'd go to a class with a teacher that the way they looked showed whether their technique they used was good or bad. And I see that a lot. I'm real involved in yoga. And it's like, everybody wants this skinny, bendy teacher that isn't necessarily the best teacher. Mm-hmm. And so I think it's just something, it's in us. It's in me where, this was just assumed. Mm-hmm. So that's really interesting.
Yeah, no, thanks for sharing that. And I grew up as a dancer too. And I think a lot of that where even if y'all can't see my feet right now, but if I'm trying to hit a fifth position where my feet are like this and my heels are the opposite, I might not be able to do that unless I have really, really small thighs, right? Does that mean it's incorrect? Does it mean it's bad? No, just means it's going to look different, and that's okay. Yeah, thank you so much for sharing that, Lori. So I want to dive into what are the repercussions of bias. So 60% of individuals who have been discriminated against because of their weight, we can look at that. And when we control for all other factors, they're going to have a 60% higher mortality rate just because they were either perceived to be discriminated against or felt like they were discriminated or were internally discriminating against themselves. When we control for every other factor, that's pretty significant. Also, 52% of women classified as overweight or obese report that their weight was a barrier to seeking routine medical care. I have so many individuals who walk in my office in this setting where I'm like, hey, who's your primary care? When was the last time we had labs? Da, 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 da. I don't know because I'm scared. Because they're scared of the way that they're going to be treated. What happens when we don't know what's going on under the hood? Lots of things, right? Higher rates of chronic disease, which is the one thing that is always associated with existing in a larger body, is higher rates of chronic disease. Well, one reason why is because, I don't know, are we screening, or are they so terrified to walk into your office as a provider that they can't get screened? Also, this is not to just throw physical therapists under the bus. Dietitians are actually pretty close up here too. 97.6% of physical therapy students categorized the individuals that they worked with who were fitting in an obese class as lazy. So if someone comes in, they're like, hey, I didn't do, for the PTs in here, I didn't do my homework. I didn't do the things I was supposed to do. And it's like, well, they're non-compliant. They're lazy. They didn't want to. Maybe the band you gave them didn't fit them. Maybe them getting up and down from the floor was not an appropriate thing for them to be doing. Is it because you couldn't think outside of the box and get curious about what works for this individual? Or is it because they're non-compliant? 40% of US adults report experiencing some sort of weight stigma at some point in their lives. That's a lot. That's nearly 40% of us, right? Also, doctors are going to spend less time with their obese patients as compared to their thin patients. Providers will also rate their visit as a waste of time. So you can see kind of the differences here in between how much time. This is almost about 10 minutes of the amount of time that a provider will give someone based on their weight. Normal weight, I may get an extra 10 minutes with them. How's that impacting care? Okay. So what we're also going to dive into now is really, what are the effects of weight stigma? What are the effects of even saying, hey, we need to go fix your body so you can get this surgery? What are the effects of saying that obesity and adiposity is a problem? Well, let me tell you, first and foremost, it's going to increase the amount of stress that someone experiences just from walking in your office. Oh, you don't have a chair that fits them? Also stressful, right? There's going to be an aspect of the physiological response here. So first and foremost, higher rates of just overall stress hormones, specifically cortisol, which is going to decrease insulin sensitivity, also mobilize blood sugar. What does that do? Decreases our insulin sensitivity, also puts us higher risk of developing type 2 diabetes. Also higher rates of C-reactive protein, one of the main inflammatory markers, as well as our overall A1C and elevated blood pressure. Imagine there's not a seat that fits you. And then they don't, who actually like test blood pressure to where you're sitting down for 5 minutes and you're just waiting there in a medical office. Not that many people, right? So imagine you're in a chair that's really uncomfortable. You also get a blood pressure cuff that doesn't fit you. What's your blood pressure going to look like? First and foremost. Also, if we're stressed, it's going to be more elevated. What does this do from an overall eating and physical activity behavior? Higher rates of cyclical, either restriction because the doctor told me not to eat that thing, which then is going to result into more binge eating, because this is a survival mechanism of our bodies. Thank you, body, for when I'm not eating enough, for telling me that I need to eat more, right? Increased caloric consumption, maladaptive weight control, meaning yo-yo dieting, cyclical dieting, disordered eating patterns, as well as lower motivation for exercise because they're like, I don't want to go exercise. That coach is going to tell me I'm bad, right? That BT is going to tell me that all I need to do is lose weight, even though my hip hurts so badly, which is going to result in overall less physical activity. Again, I don't love using weight as a metric here, but here's what they're looking at is if we are trying to overall reduce someone's weight or make them quote unquote healthier, which is what most of the research is trying to look at, it's actually doing the opposite, right? What this does is this is going to have major effects on our overall mental and emotional health, as well as also going to, again, reduce the way we're actually accessing care. So it's going to increase weight gain, overall increase our risk of chronic disease, specifically through a lot of our biometric markers, and also increase the risk because all the time we see, being obesity is related to anxiety, depression, substance use, suicidal ideation. Is it because we're being horrible people to them? Probably. This is a slide actually adapted from Dr. Sunderland, and she is a fantastic researcher. She's, I think, still based in Michigan, at Michigan State. And so this is where she actually went kind of through, and then I double and fact check this to where it's like, where are we actually putting our funds? And this is just a whole different conversation in the last few months of where we're putting our funds. We're not sure. But from the last few years of who's actually getting funded, right? Because we're like, well, the research says weight loss works. Yeah, because they have a lot of money. They're getting a lot of money. We get 9 projects. We get 9 whole projects to look at, what's the benefits of reducing weight stigma, weight bias, health at every size, weight inclusive care, and intuitive eating projects. We had 9 in 2023, as opposed to 712, right? Another thing, so we're lacking research funding. We're also lacking individuals who even know how to conduct this research, because 1% of individuals within the medical system are actually educated on how to treat people who exist in a large body. 1%. So we are lacking the people to do the research. We're lacking second, the money to do the research. And then we are also lacking aspects of overall medical equipment. Again, waiting room chairs, gowns, blood pressure cuffs. We'll even look at intubation equipment. That's all. I can't go into that. I was going to go on a tangent. I don't have time. And this is also adapted from Sunderland as well. And so if we start to look at these, I think that especially with anesthesia, I'll go into it for a second, is one of the huge things of like an elective surgery, right? Like, no, you can't get that knee replacement, you can't get that hip replacement, or you can't get access to trans-affirming care because of the size of your body. Oh, but you get in a crash? Oh yeah, we'll totally intubate you. It's fine. It's cool. Yes, there's going to be maybe some higher risk, but if we are educating anesthesiologists, again, I'm not an anesthesiologist, I'm not a doctor, but if we can educate people on how to do this more safely and also give people adequate informed consent of, hey, here's some of the risks here, instead of just saying, nope, you don't get that thing, right? Great. So we can also start to see this discrimination in care. So oftentimes our imaging and equipment does not actually fit those in a larger body. So say I'm existing in a larger body, I need to go get an MRI. I can't get an MRI because I don't fit in the machine. Oh, then I have to go down to Phoenix, which means I have to leave work. I have to find a sitter for my kids. I also have to spend $150 to go down there to get gas. Oh, by the way, maybe they don't have space for a few months. Screw it, I'm not doing it. What happens? Right? We don't get that MRI. We don't get that imaging. We don't know what's going on. Also, when we look at COVID, this was a huge thing where people who were obese had much higher rates of death. Was it also because once we got vaccines, was it because we weren't actually vaccinating them correctly? We didn't have long enough needles to actually get into the subcutaneous tissue of the deltoid, right? Then we also need to look at this is when we're looking from a gynecological perspective. For people with obesity, they had often had unsuccessful cervical visualizations due to where you're typically sitting in the stirrups. If people could lay on their side, the researchers found that, hey, there's way better visualization here and we can actually see what's going on. So if we aren't actually screening for cervical cancer, or if people don't want to show up because that's a vulnerable place to be, no one really loves going to the gynecologist for some of the people in this room, you all know. But if we make that even more uncomfortable by saying, hey, you're in a fat body, oh, I didn't get clear visualization, then what are people going to do, right? So this was a study in 2019. So this is the perceived weight discrimination mediates a prospective association between obesity and physiological dysregulation. So I want to dive into this real quick because I think it was mentioned even earlier of like, we don't know why. We don't know why this happens. We don't know why people are at this increased rate or risk of these chronic diseases, or why adiposity is so bad. It's because 27% of the total effect of obesity and physiological dysregulation stems from weight discrimination and bias. That is why. That's why it's the elusive elephant in the room that we keep running our heads against the wall to be like, what's going on? It's like, well, it's pretty simple. If I walk into a place, I'm like, hey, I'm not welcome here. I'm not going to go. So if we believe that quality healthcare is a human right, hopefully we're kind of on that same board here, are we ensuring equitable access and care for nearly 43% of the US population who technically fits in an obese category? Are we giving them equitable access to care? Early detection and intervention are essential for for preventing chronic disease. And so because of that, and we've talked about why we're avoiding care, the reasons of that, how can we call that equitable? We can say, yeah, you get this human right, but no, y'all don't. Okay, so I want to also discuss how weight-centric care not only harms people who exist in large or fat bodies, but also those who exist in smaller bodies. So this is the criteria for metabolic syndrome. First and foremost, we can't even agree on a definition of metabolic syndrome, 1A. So depending on the different, so there's the International Diabetes Federation, there's the American Heart Association, National Cholesterol Education and Adult Treatment Panel. So depending on the organization, there's going to be 2 to 3 different components and criteria that have to be met to meet the criteria of metabolic syndrome. And I want you to note that BMI is not a risk factor for any of them. Okay? So if someone's coming and it's like, oh yeah, we associate basically anything that's metabolic syndrome related as, yeah, well, I'm going to screen them for an A1C. Oh man, you're healthy, your labs are fine. Weird, I don't know why. So I think it's really important to look at this and first and foremost, understand that, again, we don't have a definition. I want to look at the overall risk of metabolic syndrome. So this was a 2020 study that looked at the predicting mortality risk of US adults across the size spectrum. So across all 6 BMI categories, what happened? So they were trying to find the relationship between metabolic syndrome and, again, the overall risk. This was a huge study. This was 10,000 people with NHANES data. And what they found was actually not surprising to me necessarily, but might be surprising to you. And so when we look at this is the rate here of overall mortality rate going up. And so the people who were in a normal weight category, normal weight with metabolic syndrome, they had the highest risk of death, right? Those who were obese without metabolic syndrome, lowest risk of death. Yeah. Interesting. So when you look at this, the conclusion was that normal weight adults with metabolic syndrome had the highest mortality rate. I would also wager that this is partially because of weight stigma. I had someone who was very, very, very close to me who had a pretty critical event last year, which could have easily been prevented, in my opinion, when I look back at medical records. Because 1, they were really healthy. They ate healthy, they exercised. They just had a little bit of high cholesterol, a little bit of this. And because they did all the other things, they ended up with a quadruple bypass because they were not being screened and treated effectively. Because they looked healthy, they ate healthy, they weren't overweight. Does that mean they're necessarily? No. Lots of other things, genetics, there's a lot of things that happen. And so normal weight individuals are going to be at a higher rate. And this really highlights the importance of looking at metabolic health assessments beyond BMI, right? This is for everyone across the spectrum, not just like, hey, I'll give you this. Again, when we look back at that surveillance data, not just like, oh yeah, this is the panel that I run for these people. This is this. How do we give equitable access to care for everyone? So we all have better understanding. We know that diets don't work. They typically have about a 80% failure rate. And that's typically after following them for 5 years, because then weight loss researchers stop following them because then the data totally tanks. So if I had a prescription medication, I was like, yeah, you know, it only works about like 20% of the time. What do y'all think? You want to buy it? No, that would not be FDA approved, I hope. So we need to think about that when we are giving the aspect or even a recommendation of, hey, go lose weight, or like do this lifestyle change. We're not going to call it weight loss, but it's kind of weight loss. We all kind of know what it is, but we need to be very clear with what we are actually doing and actually provide specific guidance of, I do not worry about this. I really hope you don't either. Here's going to be the things that I'm going to be worried about so that they actually know that it's not some weird coded Trojan horse. We also need to look at the overall aspect. I said I wasn't going to talk a whole ton about semaglutide and GLP-1s, tirzepatides, all of those things. But even after a year on these medications in the STEP trials that they published as a company, Eli Lilly, there was weight regain on the medication. Let's be very clear with that, right? Why? Because we're still here after years and years of evolution. We're still here because our bodies did not die when we were starved. Yay, body, right? Good job. You did such a good job. And so our body will metabolically adapt. If I eat lower calories, my body's like, yo, I'll match you. That's cool. I don't want to die today. Then when I go back to eating something that would have been maybe normal outside of that calorie restriction, my body's like, nah, girl, I don't trust you. We're not doing that, right? And so we see metabolic adaptation, which then results in, we'll talk about it later, but a lot of the metabolic risk here. Also, for those who come off some sort of GLP-1, 2/3 of those individuals after 1 year regain all of the weight. And after that, it's significantly either around the same rates as those who have been on a specific caloric restricted diet. So if we are trying to intervene on weight loss and saying that these are new miracle drugs and all these things, we need to be very clear that these are intended to be lifelong medications. If we are doing it for weight loss or for cardiometabolic risk, this was even the same thing there, is they saw a lot of the cardiometabolic factors and the benefits that they had from these medications also be reversed, right? So it's not just like do this for a little bit and then get off of it. This is a lifelong medication. And then we need to look at, where is that money going, right? At also maybe the risk of our own harm. I'm not saying big pharma by any means. Pharmaceuticals are fantastic. They have done a huge amount. I'm not saying these medications are inherently wrong or bad. I just think we need to have a really, really big conversation around them and also be giving a significant amount of informed consent of what are the risk factors of these medications, what happens when you go off of them. Some of the risk factors are going to include severe gastrointestinal disease. Or not disease, disorders. They have a black box warning. That is the most severe warning that you can have on a pharmaceutical drug, right? They're going to reduce overall, we talked about a little bit, but muscle mass, bone density, all these different things. And then, again, when we come off of them, unless we want to pay for them for the rest of our lives, then what happens? Okay, weight cycling. So it's pretty severe. So weight cycling is basically yo-yo dieting. The prevalence of weight cycling is pretty big. Also kind of a big range, but basically anywhere from 20 to about 50% of women have participated in some sort of weight cycling, and also men 20 to 35%. When we look at the cardiometabolic effects of specifically weight cycling alone, when controlling for every other factor, what happens is, so there's the desire to lose weight, weight loss attempts, failure to reach their goal, they dig in just a little bit harder, right? And then they end up not, because it's really hard. Who can do that? Who can just continuously go against all of evolution, starve their bodies forever? I can't. Weight regain and then overshoot, because again, we have those metabolic changes and that metabolic recalibration, which then is going to lead to that overall regain, overshoot. Can also start to see more prevalence in obesity from that, also more bias, and the conversation continues based on what I've already said today. So we see a higher risk of cardiovascular disease, 41% higher risk of all-cause mortality, increase in diabetes, also chronic inflammation, because what we are also doing is when we are going through weight cycling, we're also reducing some of the aspects of the vascularization of that tissue. And so if a tissue isn't vascularized, that ends up being problematic on a metabolic level. And so if we were to just have never done that, that would have been great. Once we are in that space, it's like, okay, if you have yo-yo dieted, great, let's find some other ways that we can just look at, again, optimizing overall health and looking at what does that mean to you and what are your goals, not what are my goals as a provider. Is this surprising to anyone? Okay.
I mean, I'm not surprised because
I'm not surprised.
again, I'm not surprised because I know a lot about like the effects of racism on mortality that we're learning about, and we're going to have to give up for the next 4 years learning about. But
no, we can still do it.
but no, I know. But I didn't realize the extent of weight oppression. Mm-hmm. Yeah, I knew it was bad, working in a bariatrics program and having a lot of friends and all that, but I never understood the extent of it.
Yeah, and I think that's also why like people are scratching their heads like, well, some people are okay. Why? There's some aspects where they're looking at different genotypes and all of that right now, but across the size spectrum again. But I think that's one of the main things. Again, we're not looking at this piece of stigma and bias of that little thing of like, I just want to lose 5 pounds. You know, I just want to like, I need to again just drop that 10 pounds before surgery so I can actually get right to access to care. That 5 or 10 pounds could be detrimental to the long-term health of someone. So what are the dangers of dieting? I want to be very clear, first and foremost, I work in the eating disorder world, and eating disorders are 100 times more common than type 2 diabetes among youth in the United States. Do we ever talk about that? Who in here has been screened for an eating disorder? Yep. If we're not screening, are we getting actual valid data? No. Eating disorders are also the second deadliest mental health condition, coming up just under opioid use disorder. So why are we always hearing about type 2 diabetes, obesity in the youth, and adolescents are so unhealthy? What about this? Here's all the other dangers of dieting. So for those who either severely diet, so severe calorie restriction, these are a lot of things that we are currently seeing on Instagram and social media. There's this thing, I told you I wasn't going to tell you about it, but I'm telling you about it now. I went down this hole because this thing that I saw about skinny talk. These are things that when I was young, there were whole Tumblr threads that were pro anorexia, pro bulimia, and a lot of things that still are talked about to this day. And now they are rebranded as this thing called skinny talk. And so when our youth are basically shown that and praised for that, they get comments, they get likes. What does this do to their brain? They feel valid and worthy. This is going to put them at an increased risk of death. Okay. Then, I had something else to say about that, but I lost it. We're going to see sarcopenia as well as nutrient deficiency. So sarcopenia is something that we're kind of starting to talk about. We've been talking about a lot. I remember I was in Italy once and like this old guy is a winemaker. He's like, yeah, I have sarcopenia. And I was like, you know that word? He's like, yeah, we've always known about that. This is something we're just talking about in the United States. But it's basically a reduce in muscle mass. We lose a significant amount of muscle mass. Brian will talk about this later. But what this does when we aren't eating enough, when we aren't also eating in a way that is helping nourish our bodies, we are going to run into muscle mass as well as nutrient deficiencies. Increase injury risk by dieting and over weight loss. So also in the aspect of wound healing. That was one thing. I don't work clinically anymore. I did. I know we have a clinical dietitian also here in the back. And so when people are malnourished, their wounds are not going to heal. They take a significant amount of calories and nutrients to heal. If you have a big gaping wound, whether it be from a burn, a car accident, so many different things, then that, just the delay in that can also increase someone's disease risk, bacterial risk, infection risk, leading to overall premature death. So if a weight-centric healthcare model limits access, fuels stigma and eating disorders, and worsens the health outcomes for everyone across the size spectrum, this isn't just a preferred approach because this is the way that I practice. This is the only ethical path forward. So what happens when we actually start to implement and look at the differences between a weight neutral versus weight loss, weight centric approach? So this was smaller-ish study, but this is 80 females ages 30 to 45 with a BMI greater than 30. And what they did was they attended 6 month or a weekly group for 6 months. There was one group to where it was just focusing on like, hey, let's like look at attuned eating, which means how do you know when you're hungry? How do you know when you're full? Can we move in ways that are pleasurable to you? Can we start to look at what does mental health look like? How do we start to look at adding things in to your diet as opposed to saying, don't eat that, don't eat that, don't eat that? Versus the other group that was given a lot of the same education, except they gave prescriptive portion sizes. They told them this is how much you should be eating. This is around the amount of calories you should be eating. That was the main difference there. And then they also did talk about weight. And so what happened? They looked at this and they measured overall blood pressure, lipid panels, including LDL, blood glucose, BMI, distress, self-esteem, quality of life. They also looked at nutrition risk. And so what that, or dietary risk. And so what that actually means, it's not like, are you doing like risky things, like risky eating disorder behaviors? No, it means basically how much foods are you eating that are from a more whole-based form versus something that is more, I guess, I just hate the word processed food, I'm going to have to use it, but more along the lines of a processed type thing. So just your overall diet quality. And so that was what they were measuring. Here's what they found. The weight neutral group had larger reductions in their total LDL cholesterol. They had improved intuitive eating scores, which means that they had enhanced attunement to when they were hungry and when they were full, meaning that they could stop as opposed to being told when they had to stop by a certain portion size. The weight loss group, we did see a reduction in BMI and weight. Granted, that wasn't maintained. We also did see a decrease in LDL levels, not as significant as the weight neutral group, but that also decreased after 24 months. And there was a temporary decrease in dietary risk, meaning that they were probably eating more fruits and vegetables, whole grains, all the things we typically do want people to be consuming. But that also wasn't sustained. Why? Because there's a binge restrict cycle, which I don't have up here. But basically, we can restrict for a period of time. Things are really exciting in our brains when we do something new, and then they wane off, and then we're like, well, that sounds good, and I really missed that. Because we haven't had it in a long time, our brain is primed to be like, yeah, cookies, we haven't had those. We've been thinking a lot about those. So when you do eat cookies, I'm going to make those that much more pleasurable. And so there was also a decline in dietary risk factors after 24 months as well. So a weight neutral approach is a sustainable health model that leads to benefits without focusing on weight, for it not even being a part of the conversation, and are viable alternatives as opposed to traditional weight loss interventions, and improve overall health outcomes. So this was kind of another evidence review here. So this is the intuitive eating and biomarkers related to cardiovascular disease in older adults. Greater levels of intuitive eating lowered LDL, and then lowered LDL and increased HDL ratios, and also lowered triglycerides. That's because also in intuitive eating, it is a protected term. There's a whole aspect around it. You can look that up later as well if you don't know what that is. And what it is those attunement to hunger cues. Right? And so that means that if we are like, hey, I know when I'm full, that's also likely going to improve our overall cholesterol and lipid panels. A weight inclusive and intuitive eating-based workplace wellness program was also associated with improvements in intuitive eating, decreased eating disorders, symptoms, as well as decreased internalized weight stigma. I will say, first and foremost, I didn't talk about it really, but employee wellness programs are ripe for weight bias and weight stigma. Yeah. They're pretty harmful. I would also look at just even kind of keep your eyes and ears out about it and start to see where you pick these things up. But if we started to look at a weight inclusive model around it, this decreased the overall internalized weight stigma across the size spectrum. Again, you don't have to be fat to have weight stigma internalized against yourself. And so that's great, because what does that do? That improves someone's self-esteem. That improves someone's ability to emotionally connect. When we're looking at workplace wellness, maybe because they're not so distracted about how they look and how they feel, they can actually get things done that are beneficial to everyone, right? And then there was also a significant reduction intake of added sugars, fast food, sugar, sweetened beverage, all of those types of things. So when people say that like intuitive eating is just like eat whatever you want, it's not. It's looking at how do we attune to that, because also people are like, well, if you told me to eat a donut and then I could have them every day, I would eat them every day. I'm like, eventually you probably wouldn't. Eventually you might want something else. And that's great, because if we don't have this rule in our head telling us, I can't do this, all I want to do is go do it. Also, we start to see intuitive eating longitudinally predicts better psychological health and lowers the use of, or lowers disordered eating behaviors. And so this is actually someone who presented last year here. So Dr. Hazard, right? Was Hazard here? Hazard wasn't here. Okay. That was maybe somewhere else I was. But basically lowered the odds of depressive symptoms, self-esteem, unhealthy weight control behaviors, and extreme weight control behaviors at an 8-year follow-up. Most overall like weight loss, that research drops off at 3 to 5 years. We have 8-year follow-ups on this. That's pretty good. We did a good job. So we look at the clinical applications of this. First and foremost, we need to be looking at the social determinants of health. I know these are not cool right now. They're really cool in my world, but they are basically the conditions that we work, live, grow, and age in. right? So this is our education. This is our work environment. This is our community, our food and agriculture systems. This is unemployment, water sanitation, clean air, housing, access to healthcare services, right? If we don't have great agriculture and sustainable agriculture systems, we don't have food, right? We can't eat better if we don't have enough, first and foremost. That's another thing, is if we don't have education around these things, if we don't have just education overall of how are we thinking, and if we don't have health-based education, is that going to maybe affect us later down the road? Yeah, probably. If we don't have safe work environments, if we don't have OSHA looking over things, that's not a safe thing. And so I think it's important to really understand that the social determinants of health have a greater influence on health than genetic factors or access to healthcare services. I don't matter at all as a dietitian if someone doesn't have enough food, if they don't have clean water, if they don't have access to healthcare practitioners who aren't going to stigmatize their bodies, right? Okay, so 40% of health outcomes are based on socioeconomic status. There are 76% higher healthcare costs in those who are food insecure. We have a significant population here in Flagstaff, Arizona, and in the surrounding areas that are food insecure. This is impacting our overall communal health. And this is not just Flagstaff, this is also all over Arizona. We are a very rural state, right? And so as we just started to see budget cuts in the very programs that keep people alive, we need to be thinking about this, because the social determinants of health, they don't just affect us, they affect our entire community, and our entire community affects us. So there's also a 31% increase in diabetes rates in women who experience racism, right? We haven't looked at this specifically in the sense of weight bias and stigma on that exact stat, but we can also look at that of like, hey, that's also not great, right? Oppression and marginalization of any kind is going to impact our overall physiological and epigenetic markers. So what is weight inclusive care? So this is the health at every size model. It is grounded in liberatory frameworks. First and foremost, it's looking at bodily autonomy. And it's also asking providers, so there's 10 principles, but it's asking providers to, again, be curious, to be competent, to critically analyze research, and to also look at how can we, again, reduce harm overall? How can we also be compassionate caregivers? Because no one goes into the medical industry, at least from my perspective, especially as a dietitian, I don't go into this to make money. I go into this because I care about people. And because I care about people means that I actually want to do the best by them by actually being a compassionate provider, right? Another thing, and you can look at these, ASDA is phenomenal. There's actually a huge description of each and every single one of these, but basically they are also rooted in informed consent. So if you tell someone, oh, you need to go lose that 15 pounds for this surgery, you also need to tell them that's going to come back. It's going to increase your risk of type 2 diabetes. It could also increase your risk of cardiovascular disease. It's going to maybe decrease your mental health. It's also going to maybe increase the risk of you being dependent on alcohol, tobacco, opioids. You want to do that? Is that 15 pounds worth it? Or do we maybe need to look at readjusting our overall surgical criteria, right? So we need to look at informed consent. We also need to look at informed consent specifically around GLP-1s. There's a fantastic, write this down if you want it later, Michigan State medical students. They also came out with a basically 10-page document around GLP-1s, the risks, the benefits, and actual informed consent around them. Because I've had so many people walk in my office and I'm like, have you had this conversation with your provider? Because they come to me asking, what should I do? I'm like, I can't tell you what to do. You get to decide what you want to do. And here's all of the information that I have. Okay. Another thing is that within the health at every size principle, as participating in it, you are also committing to addressing anti-fat bias within yourself, within your community, within your employment, and starting to have some of these conversations, right? These are big. So we need to look at also assessing our overall aspect to, do we have adequate equipment within our facilities to provide compassionate care and comprehensive care for specifically those in fat bodies who have specifically not had access to this care previously. I own a gym. That's one thing that's actually, we are always thinking about of how would someone who either maybe just broke their leg or is an amputee, or who just has a hard time getting up and down from the floor, maybe because of the size of their body, how can we make this work for them, right? It is a conversation all of the time that we are talking about, and it's something that we need to be talking about overall. Then we also need to look at assessing our tools, our educational materials, and everything that we have that support overall well-being so that they can support well-being and also not contribute to increased marginalization and oppression. So a lot of times people ask me, well, if we're not talking about weight, how are we going to measure their health? Well, there's a lot of ways. I got about 6 pillars here for you, so buckle up. First, we can look at their overall mental health, right? Mood, energy levels, emotional regulation, sleep quality, sleep duration. If someone, thank you, I'm wrapping up. We can look at their blood pressure. That's something we can do right here, right now. We can look at their labs. We can look at their lipids. We can look at their meal regularity, their availability, their attuned eating, their nutrient balance. Are they malnourished? Do they have any sort of nutrient imbalances there? We can look at their eating disorder screening because, again, no one in this room has been screened for an eating disorder. I haven't. Granted, the rates are going to be higher than those who have type 2 diabetes, so we need to be asking the question. Then we can look at their overall cardiovascular endurance, their muscular strength, their mobility, their muscular mobility, their balance, agility, their coordination. Can they balance on one leg so they don't fall over and break their hip? We can look at routine medical checkups. Are we checking up on these people? Do we have someone else who is checking up on these people? Are they adhering to their medication schedule? That's the number one thing we can do. I don't get to prescribe, but I get to talk about that. We can also look at the reduction of substance use. We can look at their overall social connection and support systems and their ability to also find pleasure in their life and their overall self-efficacy and health autonomy. So putting into practice, one, we need to screen for eating disorders. Second, before I tell someone, hey, go eat X, Y, or Z, I need to know, hey, do you have access to X, Y, or Z? Do you have access to clean water? Because there were so many times when I did work clinically, there would be someone who was here. Maybe they lived in either a rural community or on the reservation. And it's like, don't eat canned vegetables. I'm sorry. What are we going to do? Are we just telling them not to eat a vegetable then because it's too high in salt? No. So there needs to be better education. We need to look at the screening for these. Do you have access to safe and reliable housing? That's first and foremost, right? Yes. We need to look at, do you have transportation? Do you have a secure job? We also need to be screening for ACEs, so adverse childhood experiences. If you have any sort of risk within the ACEs scoring, you are going to be at a higher risk not only for emotional or mental and emotional health risk, as well as physiological aspects as well, and eating disorders. You also need to assess your own biases. And I think the biggest question I will leave you with today is if you're confused about any of this, I want you to just picture, if you have someone who's existing in a fat body in front of you and you're not sure what to do, if you're like, well, I'm not supposed to tell them to lose weight, just swap their body. What would you do for someone who is existing in a smaller body and do that if they had the same exact profile, right? I also need you first and foremost to look at, can we also ask for consent? Can we provide informed consent? And can we also start to omit body comments that are good, neutral, or negative? Because again, like I mentioned before, it's not inherently good or helpful. Hopefully you'll get access to some of these slides because I'm breezing through some of these. But again, would we actually give someone a medication that was maybe only 20% effective? No, we wouldn't. And so we need to also, when we're talking about any sort of eating change, I don't care if it's weight loss, I don't care if it's restrictive, any sort of eating or like exercise behavior change, we need to also acknowledge the risk of maybe taking a little bit too far.
Time for questions?
Yeah.
That was fabulous. One of my questions is all this emphasis on BMI when we know that other metrics like waist height and hip to waist ratios are more predictive. Why aren't we seeing more of that in the research?
So it can be predictive, but also when we're looking at, we can also start to see people who maybe also don't fit that model. So I think the bigger question is really asking, how do we get away from just trying to assess someone's health on one measure? Right? So instead of just hip to weight ratio, where it is one of the aspects of metabolic syndrome and one of their criteria met, but if it's just that, we need to look at how can I also look at some of these other factors where bodies are diverse. They're going to be different. And so I think anytime we're using just one metric specifically around body size, we need to be looking a little bit deeper too. Yeah. Does that answer your question?
Yeah, I totally agree with that. I just wonder why we're not using a more robust measure.
We're kind of shifting towards that now because everyone's like, oh, BMI not so great. We did a bad job there. But so it's starting to shift to that. And there's been conversation in the past year since the AMA made that statement about that. And then it's kind of just fumbling through like, what do we do?
Can I also say that researchers have limited funds to do their research? So they just do reported weights and heights versus like the
Actual
things
values.
that you have to do to get measures. And so I think that's also contributing to people's overuse of BMI.
Yeah, that's a great point, Dawn. Thank you. Go for it, Nick.
I think it was one of the early slides where it was like the source of stigma, weight stigma, and the physicians, family members. One of my coworkers the other day was attending a lecture, and people in the lecture were like using AI as the lecturer was talking, almost to, I don't know if they wanted to contradict the person, but it was kind of it seems like that's where everyone's kind of going for information. Have you seen anything? Do you think that's a good thing? I mean, it's the future, but how can we use that? And is it useful?
Oh, that's a big question. I think it can be useful. Granted, anytime if I were to be like, hey, say it's like, is weight associated with negative health outcomes? It would tell me, yeah, and it would tell me different reasons why. So it will confirm your bias all the time. Right. I like to use it for some things where I'm like, I have these ingredients in my fridge. What do I do with it? Right. And then it'll give me like a whole bunch of recipes I would never thought of. So I think it's helpful in some ways. And I think it may be a helpful way to, I think, first and foremost, look at how are you asking your question? Is that confirming the bias that you're asking with? Can we maybe ask the opposite question of it? And can we ensure that we're like, hey, cite your sources and actually go back and confirm those sources because we saw a little snafu this week that wasn't so great. So, so actually go through, read the research, please. If you don't know how to read the research, then you can find a lot of times an editorial journal that is based on that, and then read through a few of those. I know it takes time, but it can be helpful. But sometimes you can use some of those questions and bring them to your provider as well. Be like, hey, this is what I learned from ChatGPT. What do you think about it? And if they're willing to have that conversation, I think it can be a starting off point, but it shouldn't be your doctor or your provider.
I can ask, fantastic. Thank you. One question, a lot of what you're talking about really sounds more of how do providers prioritize their care, where they're going to start first, right? It seems that's a big piece because if you look at it, inflammation for surgery for folks with more body fat is going to be higher during surgery, things like that. So there are some markers and concerns, but it's like, okay, is it weight stigma and weight bias? Is it eating disorders? Is it then other health outcomes? And I think looking at the health markers is a no-brainer. Why aren't we just starting that and forget looking at the body size? But you're saying there is weight stigma and bias. But I guess when you're looking at maybe interprofessional care and trying to get a group in there to talk through and prioritize, we really need to deal with these issues first.
Yep.
And looking is really the goal because you can't disregard it. So there are some factors that are known, especially if we're looking at surgery, that relate to body fat, but that may not be, GLP-1s. It's not a miracle drug. We know it. It's about weight. We need to be stronger.
We need to be stronger clinicians.
Yeah.
I think that's what I'm asking all of us to do. And I think what we also need to be looking at is really having that conversation of with your, patient, I think in that setting of like, hey, here's the things that I really want to be looking at. Even if they're like, I want to lose weight. I know it's better for my surgery outcomes, being like, actually, here's a little bit of information on that. You can do what you want with that, but here's the things I'm going to be looking at and caring about. And we're going to be checking back on these things. And these are going to things that are going to matter from a blood sugar regulation standpoint, from your overall health outcomes, so that you can actually get nutrients delivered to those tissues, right? So those are going to be the things that are really going to, those conversations are going to be more helpful as opposed to, someone not having the conversation where someone's like, well, I do want to lose weight. You can be like, okay, well, you do what you want. Be like, actually, that may actually have some complications during your surgery because your gut's not going to be nourished and healed, can reduce or can increase the risk of an ileus or a GI complication under anesthesia. We're going to see, again, bone loss mass. We're going to see a decrease in nutrients, specifically vitamin C and protein, which helps with the actual collagen structure of repairing the tissues. And so we need to look at, I want to optimize your nutrition and your mental health and emotional health around this surgery. And I would really love it if we didn't focus on weight loss.
I asked, there's no questions online.
But
Hi, Aura.
Hi, Abby. I don't know if you can hear me very well. I hope you
can.
can. Okay, great. First and foremost, Ketsia, thank you so much for just the information, but also the information that you're sharing. I have both the lived experience of living in a fat, very obese body, but also I went through bariatric surgery actually twice because of some complications and probably my genetic legacy. But and I'm living a very different life now. And, a lot of the things that you have said and shared are extremely true, and they impact the way that I have sought out help. I'm Native American. I grew up on a reservation in northern Idaho. My mom is Navajo, and I live here in Flagstaff now. But growing up in the IHS system, we were extremely poor. And when we had food, right, we bulked up on the food that we had. And so we were overweight. And when we go to the doctor, all of the experiences you're sharing are exactly true. And, unfortunately, we had some other health issues that impacted my dad in particular, and childhood trauma. And, it was something that he never spoke about to any of the doctors that he saw. So their immediate response to him was to lose weight, right? Everything was centered on his weight because he was a big man. But they missed a lot of health conditions that he had, including, Alzheimer's and dementia. And so it was a really hard experience for us when we moved down here to Flagstaff, because still all of the physicians that we saw at Indian Health Service just saw his weight, and everything was lose weight and you'll be better, lose weight and you'll be better. Meanwhile, it was all of these pills that were thrown at him. And, you're right, it is a lifetime thing. And doctors never tell you that when they tell you, we'll get you on metformin and we'll help you, this will help pull all of these things down for you and you'll be better. And as Native Americans, we never ask questions. We were trained and brainwashed to not ask questions in healthcare. And so this is a rampant issue within Indian health services. And so my question is, how is this kind of thinking and this kind of education being brought into the classroom? I'm an archaeologist, and I went into that fully knowing the history between Native Americans and archaeology, but I did it to invoke change. And I feel like that's your passion as well. And I really want to see these kinds of ideas and this kind of wondering and treatment move into our classrooms. I also work at NAU, and I would love to see this kind of thought being brought into the way that our people are being trained, right? Our students are being trained, but also I think, this is something that's very useful for faculty and staff to attend and listen to, because again, it's still very rampant out there. Even though I've lost over 130 pounds, I'm still considered overweight. And I still receive a lot of, from new doctors, I receive a lot of the same stigma. And it's just really refreshing. And, it gives me a lot of hope to see the way that you are sharing information and trying to make change within the discipline. And I just really want to push a shout out to making sure that this change comes into our educational system. So it's changing the way that we are sending doctors and nurses and healthcare professionals out. But also because it's impacting people, like you said, in real time. I have family who refuse to go to the doctor because they do not want to be lectured at and finger wagged at about their weight, because they're there for other issues. They know they're fat, right? But there's other things that are happening, and we need to talk about those things and not focus on how I need to lose weight because you're uncomfortable with my big body. So just again, thank you so much. This was such a great presentation and just really thankful for the work that you do. So, yeah.
Thank you so much, Aura. I really appreciate that. And I want to just take a second to honor your experience because I'm sorry that you've had to have that lived experience. And I want to just thank you so much for sharing it because I think, again, I can talk about this in this room, but to have others share that is really important to see what is the real life actually implications of how we are existing. I would say, to answer your question, is that there's actually a few really rock star educators sitting in this room right now. Don Clifford, who's at NAU, who is actually a huge researcher and does do research on in the nutrition department around how do we start to educate these individuals on that? So in the nutrition program, I am starting to see that change, which is phenomenal. It was not a part of my education. I did a lot of unlearning to even be at the baby place where I am right now. And then there is actually at U of A, there's actually an entire weight inclusive additional training and certification that you can get as a medical provider. So whether that be you are a physical therapist, whether you're a dietitian, whether you're a doctor, and you want to have this other certification, even if you don't do the certification, if you just want to take a few classes, it is a wealth of information and it is so essential. And so that's at U of A. You can do it online. It's fantastic. We have a few people in the room here from there. So it is being talked about. It is changing. I just hope that we don't go backwards right now because that's where I'm really scared. And we need to reach more professionals, totally. So the more that we can have this conversation from kind of this hierarchical approach, that can be disseminated much more as opposed to, just someone else talking about it. So I think it needs to come from education, it needs to come from the providers, it needs to come from these places because unfortunately we do have a hierarchical care model of care to where the provider is kind of in the lead role there. And that's problematic because we don't listen to lived experience, but it's the whole thing. So thank you.
Okay, welcome back, everyone. I hope you've had a nice little break. And just thank you for Abby for that fabulous presentation. And we have another one. And I would like to introduce our next speaker, Dr. Michelle May. And she, by her own admission, is a recovering yo-yo dieter. Recovered. Okay. Oh, she's over it. Good. A recovered yo-yo dieter and the founder of Am I Hungry? Mindful eating programs and training, which offers a non-diet, weight-neutral, mindfulness-based workshops, retreats, support communities, and books at www.amihungry.com. Over 800 health and wellness professionals have been trained to facilitate Am I Hungry programs in 35 countries. Dr. May is the award-winning author of the book series, Eat What You Love, Love What You Eat, and teaches mindful eating to help individuals resolve mindless and emotional eating and senseless yo-yo dieting in the vibrant life that they crave. Welcome.
All right. Thank you. All right. So I think some of us are experiencing some of this frustration of people lining up for what they perceive to be the quick fix. But as Abby shared with us, not so much the quick permanent fix that people are hoping for. Meanwhile, the rest of us who are promoting lifestyle change are going, hey, over here, right? And so it's a difficult situation for us to be able to promote sustainable changes that are not weight-based. So our current approaches to health, as Abby did a great job of doing an overview. So this is 2 slides out of an entire slide deck that I have. But basically, our current approach is weight-centric and restrictive. So when we're talking about a weight-centric restrictive approach, it takes our clinicians and our patients down a specific pathway that may not lead where people assume it's taking them. So a weight-centric approach, this is a summary of, in one slide, what we just heard a great presentation on, all kinds of adverse effects, including weight cycling, disordered eating, eating disorders, weight stigma in healthcare, which could be responsible for a lot of the health concerns that are currently associated with weight itself. And of course, we also know that research on dieting shows that diets don't work. My lived experience is with yo-yo dieting beginning at 11 years of age, all the way through high school, college, medical school, and into my medical practice, until I finally heard my patients telling me the same story again and again and again. And I thought, wait a minute, I went to medical school. I should know how to do this. And here are all these other people that I'm working with who are doing exactly the same thing. Maybe it doesn't work. And that's what the evidence shows. The majority of individuals are unable to sustain weight loss long term. They have temporary results, which they post on Instagram, and then we don't hear from them again. A third to two-thirds will regain more weight than they lost. And so far, no weight loss initiatives to date have shown us long-term weight loss or health effects. That's what the research says, considering that it's very, very poorly funded. In fact, these are older studies, but they're classics because they went back and they really dove into randomized controlled trials. It's shocking how few there are, considering how many people are dieting and how much energy and money and time is spent on it. It is shocking how poor most of the studies are that even suggest this. And when you look at it, they really don't stand up. All right, that's really all I'm going to say about that data. I will say, adding on to what Abby said, that there is a lot of evidence that it is not us that's failing diets, but diets that are failing us. The evolution is not really in favor of restrictive approaches to health and eating for them to be effective. Our body weight is defended by a complex and powerful biological system that causes us to shift toward conservation of energy in a negative energy balance state, lowering our metabolism, increasing hunger, increasing the hedonic properties of food. In other words, food tastes better, looks better, smells better, and we lose the ability to notice satiety. I also have an entire talk on GLP-1s that I'm not going to give, but I will say one of the conversations that we're hearing a lot about is food noise. You've heard this, food noise? So food noise is this term that they're using because people are noticing that GLP-1s do decrease food noise. It is effective for that to a certain extent. But I was doing all kinds of research on this, trying to understand this phenomenon because I've been hearing about it for the 26 years that I've been doing this non-diet mindful eating approach and just never used that term. And it turns out that it's really about the cues that we're hardwired to be sensitive to food cues in order to save our lives when food is scarce. And then as we are more sensitized to food cues, we live in an abundant food environment where there is a lot of food cues, a lot of commercials and advertising and social media and people eating and food on every corner. And some people are more reactive to these food cues. And so that reactivity is referred to as food noise. I could almost find nothing in the literature about the effect of restriction and deprivation on food noise. And actually, I've already reached out to a couple of you about getting together to do some research on that. So food noise, I believe, in my experience, is highly associated with people who have spent a lot of time in their lives yo-yo dieting. And I think that's not being talked about. In fact, it's being promoted as another reason to diet when I think it's actually the exact opposite. All right, so, hang on. So we are going to talk about a weight-inclusive, non-diet, mindfulness-based approach. In other words, so what do you do instead? So what do you do instead? Because we know that this other stuff doesn't work. It hasn't worked. We've been doing it for 100 years and it doesn't work. So what we've been seeing, this is super sensitive, which is awesome. I just have to get my thumb off of it. All right, so what we've been seeing is this common vacillation between overeating, which for many people, they'll describe as feeling out of control. Now, let me be clear. When I use the word overeating, in our common lexicon, it means you ate more than the serving size, more than the portion. You over, I hate this word, indulged, right? You overindulged. In actuality, to me, overeating means you ate more than your body needed and you feel uncomfortably full. That's a much better definition. It's an internal definition. But nonetheless, the people that I work with will say they feel out of control. And they respond or react to that feeling of out of control by attempting to regain control by going into some restrictive plan, a diet, some kind of a eat less, exercise more advice plan. And so what happens is they're vacillating back and forth between these two states because neither of them feel good. When they are overeating, they feel uncomfortably full, they feel guilty, they feel like they're failing. And then when they're restrictively eating, they're missing the foods they love, they can't go to their favorite restaurants, they can't eat their familial foods, et cetera, et cetera. So it is an endless state of discomfort. And so I want to propose mindful eating as a solution to this, by thinking about it as being in charge instead of trying to control your diet. So in charge means that you are consciously making decisions about what to consume and when to consume it, etc. So it is an inside out approach as opposed to the common outside in approach where some expert is telling you what you should do. Does this make sense? Pretty simple idea. So my slides from here on out are not data heavy. They are designed to get you into your own experience and to have you become curious. And for those of you who work with people on a regular basis on these issues, I think you're going to see some of what you've bumped up against. And maybe you'll even say, oh, I always thought that, but I didn't know how to articulate what I was experiencing in my work. Okay, so we'll use the mindful eating cycle. This is a model that I developed 20 plus years ago to help me organize these decisions that people make. We heard the term intuitive eating. I have not been intuitive eating trained, but there's a huge amount of overlap between what I'm about to teach you and what you will already know from intuitive eating. What we did, though, was we added some structure to the way that intuitive eating teaches people so that they actually know, okay, there's decisions that I'm making. So specifically, there are 6 decisions that you make every single time you eat, probably mostly unconsciously, right? So the decisions are, why am I eating in the first place? What is the purpose for eating? When am I eating, or when do I want to eat? What do I eat? Which is a big part of what the restrictive diet culture focuses on, is what you eat, right? It's important, but it's only one piece of the entire cycle. How do I eat it? In other words, how do I consume it? How much do I eat? Again, another focus on most restrictive approaches. And then where do I invest the energy? Where do I spend the energy that I've consumed? And so that is also the other piece of the diet cycle: eat less, exercise more. So we're going to look at a few kind of high-level ideas with each of these. This is just an overview, just a way of getting you thinking about mindful eating as a possible alternative to restrictive dieting. Trust me that there are skills that go with each of these. It's very much a skill-based approach, based on helping people develop an inside-out way of making decisions. All right, so why? Why do we do this? Well, when we are mindless, we are literally out of our minds. We are not using our frontal lobe, our executive function, to make decisions. So you walk into a movie theater and immediately you want popcorn, right? That is a Pavlovian response, right? Exactly. So you start salivating like a dog whenever you go to the movies, because you have paired the cue with the availability over and over and over again. And so that connection becomes almost hardwired into your mind. And when you are mindless, you're not using your executive function, you actually have no choice but to react to that cue. Because when you're not thinking and making decisions consciously, you have to react out the past. That's all your brain can do because it can't make new decisions if it's not online, right? How many of you have ever pulled up to a four-way stop and had no idea who was next? You ever done? Yes? That's mindlessness. We're operating a 2,000 pound, to however much a car weigh. How much does a car weigh? About that, 2-ton vehicle. And we don't know who gets to go next because we're on autopilot. We can easily do that with food, right? So with mindfulness, you don't have to change where you go or what you do. You can still go to the movie theater. However, when you notice that you're craving popcorn, you go, huh. Remember curiosity that we heard from Abby? You get curious. You go, huh, this is funny. I'm craving popcorn, but we went out to dinner before. I'm not hungry. What's going on? So mindfulness teaches you to pause between the trigger and the reaction, which in other words gives you the ability to respond instead of reacting out of habit. Simple idea, right? Very simple concept. Now, by the way, and the people I work with all the time say, oh, this isn't just about food, is it? No, this is about a lot of things that we do in our day-to-day lives. So let's focus on each of these decision points for just a moment and talk a little bit about some of the nuances here. So the question, why do I eat, often gets overlooked. I want to hear from you. Why do you eat? We're going to have a lunch meal here shortly, and I will actually do a guided mindful eating experience with you. And as a prelude to that, I want you to think about, why are we going to eat today together? Okay, let me hear from some of you. Why do you eat? Why are we going to eat? It tastes good. So pleasure, excellent. We're boredom. We're bored. Okay, that's certainly a very common reason for eating. No, I know. Oh, thank you for clarifying. Woo, Steve, goodness. It's a social response. It's a social connection. Excellent. What else? Comfort. Yes.
Family, like history of things we ate.
Connection, right? Memory, connection, comfort. Nicholas. Stress relief. Yep. Fuel. Oh, wow. Eating for fuel. How novel. Yes.
I was going to say, 'cause I'm hungry.
Because you're hungry, which, as we'll talk about, is your body's indicator that you're needing fuel. Any others? Abby? Yes. The time of day. That's an association, right? Nutrition.
Yeah.
Oh, nutrition.
Nourishment.
Oh, nourishment.
To nourish our bodies.
Exactly, right? So nourishment. So we were born with an innate ability to know when our body needs fuel. This is something that is highly developmental, highly hereditary, genetic, built-in, evolutionary, and it can be unlearned. And sometimes we start to teach young children at a very young age how not to do this, how to eat because it's convenient for us, or to finish off the last of the bottle so we can try to get another hour of sleep, right? We're doing these kinds of behaviors and causing children to override. The younger they are, the less likely they're going to respond to that. But the older they get, especially when we start rewarding, I was a psychology major at ASU before I went to medical school. So I do a lot of psychology in the work I do. This is operant conditioning. You give somebody a reward and they will re-engage in that behavior again and again. And we do this with kids all the time. So if you have children or have any influence over children, recognizing that rewarding them for cleaning their plate is unlearning their instinctive ability to know when they've had enough in a food environment that has, more than most of us need. We also have these triggers, these on and off triggers. I heard stress, comfort, boredom, socialization, and there's nothing wrong with that. I mean, it's normal to have emotional connections to food. We all do. It's part of normal eating to sometimes eat for emotional reasons. Where people get into trouble, and a lot of the people that I work with, it has become one of the main ways that they're caring for themselves, or a preferred way, because it's simple and it's effective. The problem is it's temporary. And so you have to redose or re-up in order to get the same effects. And that's where they oftentimes will feel out of control because they find themselves needing to redose to get the same effects. Does that make sense? So again, making emotional eating a problem is counterproductive. People who don't struggle with food eat for emotional reasons. We all do. It's part of our eating. And social connection and connection to memory and family and things like that is really important. And it's one of the reasons diets are so ineffective, because they disconnect us from our emotional connection to food. Now, of course, fad dieting, that's even an old term now, isn't it? And as you pointed out, it's wellness now, or eating whole foods, or organic. I mean, there's a lot of variance on this now, but let's not kid ourselves. It's just the same wolf in different sheep's clothing. This way to restrict or deprive ourselves. But for the most part, most of these so-called plans completely ignore why people are eating in the first place. And, we tend to eat because of all of these cues, these learned cues that we have. And some of these are some of these are very pleasurable, pleasant, etc. But the truth is that if we're doing them unconsciously, we may not have a connection to what our body actually needs at any given time. And I do point out here on the bottom right, restriction and deprivation is an emotional cue for eating. It's a very powerful driver of the cycle. And oftentimes, this is completely overlooked. The treatment is actually contributing to the challenge that people are trying to address. It's a good business model, though. Speaking as someone who went back to Weight Watchers 17 times, I'm very persistent. But it dawned on me one day, if somebody had said, Michelle, you restarted medical school 17 times. It might be time to say this isn't working for you. So that was kind of my give up, right? All right. So why you're eating is really important, and it's often overlooked, but it will affect every single decision that follows. It'll affect when you feel like eating. It'll affect what you eat. It'll affect how much you eat. It'll certainly affect how you eat. And so all of the decisions that are occurring are affected by why you're eating in the first place. So you've got to start with the why. What's happening? What is my intention here? All right. Now, where a lot of people will be conscious of what they're doing is they'll notice they feel like eating. So I will often say to people, don't worry about why you're eating, but notice that you feel like eating. That is a wonderful idea, a wonderful opportunity for awareness when you notice that you want to eat. So when the thought, I want to eat, pops into your head, that's where the pause takes place. This is the moment to check in and get curious. So we teach people to ask the simple question, am I hungry? So that it helps bring them into an internal awareness of what's happening bodily. It's no different from me driving up from Phoenix yesterday and seeing a gas station and deciding, I better check and see if I need gas before I go on, right? Like, I wouldn't pull off every time I saw a sign, would I? Yet, oftentimes people are popping food in their mouth because it's available, because it's there, without checking in to see what their own fuel gauge is telling them. So asking, am I hungry, is just checking your own fuel gauge. Pretty simple, right? So we have the ability to identify our own bodily needs. So one mindfulness skill that we use is a body, mind, heart scan, where we are asking people to pause for a moment, check into their body, their physical sensations. They're looking, of course, for hunger, which we'll talk about in a moment, but they're also looking for fatigue, thirst, discomfort, even just antsiness. Like one of my big eating triggers when I was struggling with this stuff was mid-afternoon. I'd be trying to plow through a project that I just didn't want to do anymore. I was tired of it. And I didn't have enough self-awareness to realize I need to get up. It's time to go do something else, shift tasks or move my body. So doing a body, mind, heart scan can make you aware it's time to shift and do something else, even for a little while. So the symptoms of hunger are what? Tell me, what symptoms do you get when you're hungry?
Can't focus.
Can't focus. Grumpy. Yeah, that's not what my husband calls it, but yeah, grumpy. Fatigue, you can have a drop in energy. And that one's a tricky one, as is grumpy, because it can also come from other things. So just feeling tired may or may not be hunger, but it's absolutely one of the possible symptoms. Excellent. What else?
Thinking about food.
Thinking about food. So we start to think about food. Again, you have to differentiate that from what they're calling food noise, but it's just this, I need to eat something. I want to eat something. And it very well may be your body's indicator that it's time to start planning a meal. Others? Okay. Okay, great. So an emptiness, gnawing, growling, grumbling, yes. And it can be uncomfortable. It can absolutely be uncomfortable. My mother used to call it hunger pangs at the beginning. I thought she was saying pains. I didn't want pain. Can't have pain, but pangs like, hey, time to take a break or think about putting something on. Anything else? Did we miss any? A headache, yes. So by the time you're getting to the low glucose level of hunger, you're having headache, maybe shakiness. Certainly that's where the irritability comes from. All right, so hunger pangs, growling, emptiness, queasiness, irritability, headache, low energy, shakiness, difficulty concentrating. We got them all, right? So you may have your own little set that you'll learn to identify or already know as your signals of hunger. These occur on a continuum. We use a hunger and fullness scale to help people gain more awareness of how hungry they are. It also helps them figure out how long before they really need to eat and how much food to order or prepare or serve themselves. So it's very useful in decision making. One little tip that I will give you is that one big trigger for eating more than you need is being overly hungry. Because at that, right, I'm seeing a lot of head nodding, because at that point, your blood sugar is starting to get low and your brain is not firing properly at that point. And so you may order more food than you need, you may eat fast, and you may go from uncomfortably hungry to uncomfortably full. Yes.
Really hungry.
Yes.
Also, no idea.
Well, here's my tip for you then. Being really, really, really hungry doesn't mean you need more food than usual. It just means you need to eat soon. The capacity of your stomach and the need for energy is about the same as any other level. It means you need to eat soon. Okay? Okay, there you go. All right. Now, we're not asking the question, am I hungry, to decide whether you're allowed to eat. So there is, when I first started talking about mindful eating, there wasn't a lot out there. And now it's exploded, as has intuitive eating, but it's also completely misused. So I want to give you a few things to watch out for. If you're seeing people talking about mindful eating for weight control, in my opinion, that is not mindful eating. That is mindful eating, right? That is not the intention of mindful eating. That's a misuse. If you are seeing people say, well, if you're not hungry, you shouldn't eat, that is not mindful eating. That is another form of restriction, right? It's not abnormal to eat sometimes when you're not hungry. So the purpose of asking, am I hungry, is not to decide whether you're allowed to eat. It's to help you figure out why you want to help you notice, oh, I'm bored. That may or may not affect whether you eat, but at least if you choose to eat, you're going to know that this is boredom. And here's the problem with boredom eating, Steve. As soon as you stop eating, you're bored again. So you have to eat again. Yes. So that's the problem with it, right? So that's where you get that awareness. And sometimes it'll be like one round of boredom eating. Then you're like, oh yeah, that's not working for me. Okay. All right. So if you're not hungry, what you're needing probably isn't in the refrigerator. This is a whole other discussion, a whole section of the programs we teach is how to help people begin to develop their emotional vocabulary and their awareness of what their emotions are telling them. So here's the amazing thing about mindfulness is that your body is constantly giving you information to help you take care of it. Your entire sensory system is here to help interface between the outside world and the inside world. So when you're aware that you're hungry, that tells you that you need fuel, right? When you're tired, you need sleep or rest. And you're thirsty, you need water. And when you're stressed, you might need help, a break, to say no, that you might need a lot of different things. And so a lot of the work, and this is why it's so much easier for a doctor to say, oh, your BMI is high, eat less, exercise more, is because the truth is that part of the challenge that we have is that people don't have the basic skills of listening to their body's needs and practicing self-care in response. And so some of this stuff has to take place in conjunction with a therapist or with a coach or with a dietitian or with somebody that they trust and can work through. Make sense? Yes, Brian.
Would you also say that, well, providers, we are all human. Providers have to have some understanding of this for themselves in order to be able to teach it, right? It doesn't have to be perfect, but at least knowing some of the concepts and working through that on your, which is hard.
Yes, it is. It
We're all
is.
human. Yeah.
I agree. No, I totally agree. I can't solve the bigger world. Although I just approached Ashley and said, please, can I teach at U of A? I do teach mindful eating at ASU and a lot of health professionals that come through the class, and it's very helpful. I think it changes the way they practice eventually. When I'm doing my own training, I do immersive training. Everybody goes through the program, and how many of them come out the other end going, yeah, I came here because I thought I had a pretty good, healthy relationship with food, and I just wanted to teach other people how to do what I do. I didn't, and I needed this. So I think you're exactly right. Here's the problem. You don't know what you don't know. You don't know what you don't know. I spent many years sending people to Weight Watchers because that was my diet of choice. And I always hoped that they would do better than I had. I didn't know better, right? And that's unfortunately where a lot of clinicians are getting their information, is the same place their patients and their clients are. So good point. Okay, well, invite me back. We'll do a deep dive. Okay, so here's sort of the general idea here is if you can think of all your needs as falling into one of two buckets, your fuel needs and everything else. You can think of it that way, that simplistically. When you feel stressed and not hungry and you eat cookies, which bucket are you filling? Nope, you're filling your fuel bucket. It feels like you're meeting your other needs. You get some temporary pleasure and comfort. Yes, yeah. So you get the temporary reward of it, but your other needs bucket is still empty. And so this is one of the, in my opinion, one of the causes of food noise is because your other needs are screaming to you to be taken care of. And if you think that, well, cookies helped, more cookies will help more, then you may keep filling the fuel bucket and your other needs don't get taken care of. So that's the skill set that is often lacking. And it's not their fault. Our parents didn't know. You know, they didn't know unless you were raised by a therapist. You know, they taught you the same things. They said, don't cry or I'll give you something to cry about. That's what my mother said. Right? Or you're a good boy, I'm going to give you a cookie. Like you learned these things. Okay. Now, sometimes I want a brownie means I want to break, I want to talk, or I want to scream. And sometimes it just means you want a brownie. So this stress about don't eat certain things or it's a bad food, enjoy it. Get the pleasure out of it, the comfort out of it, and then let it go. The guilt, it will drive more eating. All right, so let's assume for a moment that the answer to the question is yes, I'm hungry. So let me pause here. I don't want to move too fast because we're getting close to a meal. So let me have you do a body. You guys want to do a body, mind, heart scan real quick? Okay. So close your eyes if you're comfortable doing so, or at least just find a soft gaze. And we'll do a brief scan of the body. So starting at the top of your head, just pay attention to your physical sensations, not your thoughts. We'll get there in a minute, but your physical sensations. Notice any tension that you have in your forehead or in your face. Are you clenching your jaw? Notice salivation, which is a sign of appetite, not hunger. It could come with hunger, but salivation is not hunger. And then scan downward. Just notice your breathing. Can you feel your heartbeat? Some people can, some people don't. It's a difference between individuals, especially without training. Now make a fist, a light fist with your right hand and set it over your stomach. So I know you guys know, but let me just say, your stomach is an organ inside of your abdomen. So when I was little, my mom would talk about my stomach and she was referring to my abdomen. Do you have a tummy ache? Your stomach is an organ about the size of your fist when it's empty, and it sits right at the top of your abdomen, underneath your breastbone, underneath your rib cage. And so putting your hand there helps you draw attention. So I'll be quiet. Just notice what you feel there. Earlier, we talked about pangs, emptiness, hollowness, grumbling, growling, or maybe your stomach is full. Maybe you've already eaten or you've had a big drink or something and your stomach feels full. Just notice that without judgment. Now, the contractions, by the way, are always happening, but when your stomach is empty, you're more aware of them. Okay, that's why we feel that grumbling and growling. All right, notice your blood sugar symptoms. Notice anything that feels like low energy, headache, shakiness. Also be aware of anything else that you might be confusing with hunger or might compound that sensation, like thirst, fatigue, pain or discomfort. So that's your body scan. Now your mind, just briefly notice any thoughts like, come on, let's get to the food, or, you know, anything that you may be thinking right now. It's time. And then your heart scan or your emotions. We call emotions feelings because they cause physical sensations in the body that you can become attuned to. So notice whether you're having any emotions. Again, boredom, excitement, maybe something else is happening in your life that's entering your awareness right now. And based on all that, we won't do a full hunger and fullness scale. Just give yourself an answer. Yes, I'm hungry. No, I'm not hungry. If the answer is yes, are you a little bit hungry, a lot hungry? Just kind of know generally where you are right now. Okay, take a big deep breath and then let that go. All right, so we have the intuitive ability when we're born to know this, but many people have unlearned it and forgotten it. And so the practice of doing a body, mind, heart scan is about re-engaging and reconnecting the body and the mind. Okay. All right. So let's assume that the answer to the question is yes. Just out of interest, out of a show of hands, how many of you would say, yes, I am hungry right now? Okay. Maybe half. All right. So if you're not hungry, you can still eat. Yeah, exactly. This is not a rule. Oh, you're not hungry. You don't get to eat. You know what'll happen if you start teaching your patients that? They aren't going to want to ask the question. Because if they want to eat and they think if I ask and I know I'm not hungry, I'm not going to be allowed, they're not even going to ask. So just know, and again, another whole other talk, but just know that eating is still an option. Just know that you aren't hungry because it will help you sort of figure out what you're really, because here's the thing I used to do when I was doing a lot of dieting. I wasn't hungry, but I felt compelled to eat. And then I would go and choose something that was allowed on my diet, like a rice cake. And then not only did I not need the energy from a rice cake, I wasn't getting any pleasure either, right? I was getting nothing out of it. I once posted on social media, how many rice cakes does it take to satisfy a craving for chocolate? And somebody responded back, 6 and a Snickers bar. Right? Of course, that's right. Okay, so if you are not hungry, you can still eat. And today, if you want to just experience a mindful eating experience, you can do it with a few bites. We didn't have that in our list of reasons we're eating, but today we're also eating for learning. We're going to try to experience this, which means I also am slowing this down to be able to teach it, but it doesn't need to take 30 minutes to eat a meal mindfully. Again, another red flag. If you see mindful eating and they insist that you do it in silence by yourself for at least 30 minutes, that's, yeah, ooh. It can happen. It can be that way sometimes, but that's not mindful eating. Okay, so let's talk briefly, very briefly about what to eat. So this is an area that a lot of people go down the diet pathway. And these pathways are deeply ingrained. We have lived in diet culture for my entire life. Many of the people I work with tell stories about their mothers dieting and messages and sneaking AIDS candies from under the, yeah, do you guys remember those? Some of you are too young. They were these little caramel, I think, stimulants. I'm not even going to guess how many children ate these little caramel stimulants because they tasted good. All right, so a lot of people get into this good food, bad food decision making. I should, I shouldn't, healthy, unhealthy, carbs, whatever it is, whatever you're counting. And so it ends up turning these foods we're trying to encourage people to eat into a 4-letter word. So people don't even really want to eat them because they associate them with restriction. Now, here's what happens. When you have a long list, and your list will vary, this one says, I won't eat ice cream, potato chips, bread, cake, candy, fast food. It might have other things on it, but when you have a list like that, you end up creating a cascade of events that we've talked several times about. And the longer you go without these foods you enjoy, the more you feel deprived, the more you will have cravings or food noise, and the more powerless you will feel over those foods. And so when they appear in your environment, it's not if, they will appear in your environment. And in fact, the more you restrict and deprive, the more attuned you're going to be to where they are in your environment, because you have to, because you got to avoid them. So you will always know when cupcakes show up in the break room, right? You will now the fruit basket will sit there till it rots, but the cupcakes, everybody in the office will know in a very short period of time. So the thing is nutrition information is not a weapon. We should not be using it against people and against ourselves. It's not a religion either, but it would seem like that, right? Just hop onto social media. You would think the amount of time that people spend talking about this stuff, that it is so, and you'd have to ask the dietitians in the room. However, the studies really don't support that that your diet, your nutrition is more than about 5 to 20% predictor of your well-being. Social determinants of health, physical activity, genetics, there's a whole bunch of other things that have much, much bigger impact, but you would not know that the way that we spend so much time talking about it. Do I believe in balanced eating? Yes, I do. Not a big fan of the word healthy eating anymore because it's being used against people. So balance. So for me, balance is about balancing eating for enjoyment with eating for nourishment. And maybe not in the same meal, but over the course of the day or the week or the life, it's a balance. Variety will help ensure that you're getting the nutrients that you need. And then moderation sort of accounts for, I hate portion size. I hate that. You have a built-in barometer of portion size. You don't need to weigh, measure, count, or log food. When you become attuned to your body's signals, you will know when you've had enough, right? And also moderation in moderation. Sometimes, right? Sometimes you're going to eat what you want and you're going to enjoy it, right? Okay. So let's move to how. This means we're getting very close to our meal, and I hear that the food has arrived. So in a moment, we'll take a break. And for those of you watching online, I hope you will play along with us and wait to eat until we do this. So how you eat is really what a lot of people out there think mindful eating is. It's just how you consume food. That is a piece of it, but as you can see, it's only one piece of it. It's so much more. It's all the decisions that go into it. So what kinds of things distract you when you're eating? Your phone, the computer, television. What else?
Cribbage. We play cribbage
while we eat. Okay, I have not heard that one yet, but thank you. Yes, that's good. Anything else? Social, right. And again, this is maybe where some people think you have to eat in silence, but social connection around food is such an important part of eating and nourishment. And so learning how to do it in a way that causes you to not be distracted is important. So we are distracted by TV, we're distracted by work, we're distracted by driving, entertainment and social events, studying, reading, and also secret eating. This is something that I see a lot in my work because people have learned to feel ashamed of their eating, especially in larger bodies. And so it has this counter effect of causing people to go in the dark to eat, which only adds more shame burden, which increases eating. So I really encourage people to eat what you want, no matter who is there. And sometimes you have to have conversations about setting boundaries, right? It is a Pandora's box. I know, it's easier. Just, yes, Brian.
Do you know if there's any research on satiety and eating what really distracted, or I'm thinking particularly at work in front of the computer and lunch, and then people talk about how they feel in the afternoon. And so I wonder if that affects our satiety signals or.
Yeah, absolutely. So the general principle of mindlessness or mindfulness, these two opposites, is that if you're not paying attention, you won't be aware of your physical signals. And the other thing that happens is when you're doing something else, you're not getting the enjoyment out of the food, you're not getting the sensory experience out of the food. So you keep eating more because you don't even remember the last 32 bites you took. So there's a lot. Now, if you're really interested in this, Brian Wansink did a ton of research on mindless eating. Fascinating. Some of his stuff has been discredited, so I'm a little, I don't know which is still valid. But for example, he did this famous soup experiment where he brought people into his food lab and he had pre-rigged it with bowls on the table that had tubes running underneath with a tank, a fill tank. And so he would have these people in under the guy, you know how I was a psychology major. I used to run these things, we'd tell them it was about something else. And we're just going to have this conversation about whatever. And so people would eat. And so if they were on the intervention where the bowl was refilling, they just kept eating. They just kept eating because they were looking for the external cue of the soup level to drop to determine when they'd had enough. They were not paying attention to their body's signals. He did a bunch of really fun and interesting studies like that. Yeah, I won't say anything more about that, but you can also research some of the challenges with his food lab, but he did some really cool stuff. Okay, all right, so what happens when we eat mindlessly? When you are disconnected, this was your question, Brian, so what happens when you're not paying attention? Not as enjoyable.
Great.
You end up eating more than your body needs, right? You end up cleaning your plate. You're looking, as I said with the soup bowl, you're looking for the external signal to say eating is done. And so that's the value of paying attention. So mindful eating, I think a really lovely, simple definition is eating with intention and attention. Intention and attention. So intention is purpose, attention is awareness. So we talked about the why, we kind of brainstormed why we eat. So fuel, so again, for yourself right now, fuel, enjoyment, and those are not mutually exclusive, are they? Nutrition, social connection, comfort, distraction. And then my favorite intention is to feel better when I'm done eating than I did when I started. So think about that intention. I want to feel better when I'm done than I did when I started. So that means that I have to be a little bit uncomfortable before I eat, like a little bit uncomfortably hungry to actually feel better when I'm done. I need to choose something I enjoy, and I need to eat it in a way that gives me pleasure. And I will probably want to stop before I'm uncomfortably full, right? So that is a great intention for me. You can borrow it if it works for you, but decide. Like sometimes a meal is just about nutrition. I'm kind of that way about breakfast. Like breakfast is not, I'm not a Denny's skillet or pancake. That is just not my thing. For breakfast, get her done and then get on with the day, right? So that for me will be a nutritious, smaller meal. But maybe lunch. My husband's a professional chef. Oh, my parents own Mexican restaurants in Phoenix. So 4 of them. So yeah, I'm into it. We're into food. So I'm going to have varying levels of this. And so knowing that will really make me very conscious to choose something that I enjoy. Okay, so does everybody have a clear intention for our meal? All right, so we are going to eat with awareness. It increases your pleasure and satisfaction from eating. It'll allow you to tune into hunger and satiety. It makes it easier to stop at a comfortable level, and it helps you notice how certain foods and situations affect you. Social eating, rushing, things like that. So it's really just about noticing what is in that present moment, bringing in curiosity. So we are going to take a brief break here to get food. The food is out here. What I'm going to ask you to do is please take what you want. Nobody is going to judge what you eat. And in fact, I would suggest to you that any sense that other people are judging you is more about them than about you. So it's really important to just let that go and eat what you want to eat. Again, this is much easier if you're in a smaller body, because for whatever reason in our culture, I know what the reasons are, I'm kidding you. I know what the reasons are, but people seem to think that they have a right to judge and comment on other people's food. And that's so inappropriate. And if you do that, how many of you know people who will say, "Oh, do you know that there's blah, blah, blah chemical in that?" Or, "Oh, you know, that's not." How many of you know somebody like that? Raise your hand. If you don't have your hand up, it's you. Just say, yes. Okay, all right. So we're going to take a break. The only other thing that I would say about this is please don't eat anything until we're all back together. If you do find yourself popping food in your mouth, please chuckle and go, "Oh, this is that mindless eating thing she was talking about." It's very automatic to put food in our mouths. Okay, it'll take about 5 minutes. Also a good chance for a bio break if you need it. And we'll come back together and we'll start our mindful eating experience. And I'll hang out up here if you have questions. All right, so let's continue. Are we good? Are we good to go ahead and start? Yes? Okay, great. So mindful eating is eating with intention and attention. Okay, so intention is our purpose. Remind yourself of your purpose now, because we have this phenomenon as animals that when we are in the presence of food, our brain goes offline. We just forget. So you have to keep checking back in again and again and again. Now we're going to move to how much. In this specific eating occasion, it came as in a box. It has whatever it has in it. This is what it is. Now, certainly you had choices about chips and brownies and drinks and things like that. But this is very similar to many situations where the food is served to you. In other words, somebody outside of you determined what the portion size was. And so you have to re-engage with your own body's needs to determine, of the amount that I have here, how much do I need? Because this is not the right amount of food for you, probably. I don't know. Maybe it's not enough. I don't know. So we call this the Goldilocks zone. This is not too much, not too little, right? So how do you get to the Goldilocks zone? We talked about the intention, how you want to feel when you're done. There are some meals, frankly, that are just worth it, right? Like, yeah, people say, "Yeah, but we're going to be in Italy." And I'm like, well, then you better enjoy what you're eating, right? The other thing you can do is create a speed bump. So before we eat, let's go ahead and look at what you have. Open your box if you haven't already. Gauge what you have in your box there. And remember the level of fullness you thought about earlier when we did the body, mind, heart scan? Now compare that to your intention for how full you want to be and predict how much of the food that you have you need to get from where you are to where you want to be. That makes sense? It's going to vary based on what the food is or which foods you choose. In my case, I'm driving to Pine Top. When I'm done here, I'm taking chips and brownies and I'm stashing them into my computer bag, right? Like just because you have it doesn't mean you need to eat it now. It might be another eating occasion if it's more than you need. Make sense? Yeah. Okay, so you create a speed bump. So a speed bump is where you divide the food in half, because speed bumps slow you down. You are not dividing the food in half because you're only allowed to eat half. That is an old diet trick. I do not recommend that. Just remember, when you hit your speed bump, pause, check back in again. Put your fork down, put your food down, maybe take it out of your eyesight, and just chat for a few moments. And then go back and say, okay, now how much do I think I need? You might be surprised that after your speed bump, you may not need the other half. You might, or some of it, but you'll at least have a chance to check back in again. All right. Are you still being attentive? Sometimes we start out mindfully, and then as soon as we start eating, we kind of get on autopilot, and then reestablish how much you need. Okay, so we are going to do a couple of mindful bites, and then I'm going to sit down, eat with you, and I'll check back in and see how you did here. but just keep your intention in mind. This is not about being good. This is about feeling good. It is an inside out barometer of how much to eat and how to eat and what to eat. Okay, so first of all, just have a little visual feast for the eyes here. Take a look at your food. Make eating a multi-sensory experience, beginning with the appearance of the food, noticing that somebody prepared this lovingly, even made sure that there were options for people with nut allergy or gluten intolerance, etc., which is very kind. And we can have some gratitude about that. And in fact, I think starting every meal with a moment of gratitude is incredibly important because we are very lucky to have access to food so frequently and so regularly. Delicious food, even processed food that's delicious, right? I mean, we're very lucky. All right, now with an attitude of gratitude, what bite is calling to you? It might be the brownie or the chips. Forget what your mother said about eating your vegetables first. When you eat your vegetables first and save the best for last, you will get to the end of your meal. You may be full and you will still eat your favorite because that's what you were excited about, but it won't taste good anymore. You won't enjoy it and you may be overly full. Okay, so choose what you're going to take a bite of first. Get a little bite in your hand or on a fork. A small bite. Bring it up to your face and pause to smell it. Aroma is a really important part of the sensory experience. Now put it in your mouth, put your fork down and show up to the party. I'm going to be quiet for a moment here and let you experience what you're tasting right now. Chew it, enjoy it. Eating is noisy. I'm sorry. Don't be too self-conscious about it. It just makes noise. That's part of eating, right? Now, how many of you would have already picked up your phone by now or started loading your next fork full of food by now? Right. So, and if you're loading your next fork full of food, which fork full of food are you paying attention to? The next one. You're always paying attention to the next one, not the one that you're eating. And so you're not done until there's no more forkfuls left to load. So by mindfully enjoying each bite and making each bite a discrete experience, you're going to get much more out of it. Okay, let's do one more bite or two more bites. I'm going to talk you through maybe two more bites. The next one, again, decide which bite do you want now. Remember to smell it. Put a small bite in your mouth, and I want you to notice the sensations on your tongue. Remember, we learned this in kindergarten. Sweet, salty, sour, bitter. We didn't learn this in kindergarten, but umami, right? Savory or deliciousness probably comes from glutamate. So that's all your tongue is tasting. It's getting texture, temperature, and those 5 sensory experiences. It's spicy, by the way, which is not a taste. It's a texture. It's sharp, you know. Everything else you're tasting is coming from the aromas. So that's why we want to smell our food. It's why we want to take a small bite, because if your bite is big, then you're going to block the air from going up your nasopharynx or your oropharynx back up into your nose. So you won't actually get to smell your food. Okay, another bite. Whatever you want. This time, notice how you know exactly what to do. You know how to pick up food. You know how to get it into your mouth without making a mess. You didn't always know that. That was part of the eating experience, was to learn how to control food on a fork or a spoon. And you know when to chew it. Now, if you go chomp, 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 swallow, you're missing a lot of the experience. The taste, the fun of eating occurs here. You don't really taste anything as it's going down your esophagus. So slowing down gives you the chance to really experience it, and it also gives you a chance to notice. So sort of visually imagine each bite dropping down and filling a small space in your stomach, just to help you kind of connect with what you're doing here. All right, I'm going to be quiet, eat a little bit myself, but I would encourage you to chat with one another while you're eating. And my suggestion is just to practice shifting your attention. Social eating is great, but just shift your attention and put your fork down while you're talking. And then maybe while the other person is talking, that's when you take your bite and chew and shift your attention back and forth. I'll come back up in a few minutes and wrap this thing up and find out how your experience was, okay? I'm going to be sitting over there if you have any thoughts or questions, and I'll see you in a few minutes. Don't rush, by the way. There's no hurry. You can eat until you're done. Okay, I want to invite you to continue to eat while I finish up here. Again, this is just an opportunity to practice shifting your attention. And if you notice yourself becoming mindless while you're talking or listening, just notice that. So mindfulness is awareness of the present moment without judgment. So if you judge yourself and shame yourself because you got mindless, you're missing the point. I always tell people, if you notice that you're mindless, you're mindful again. The moment you go, oh, wait, I'm watching TV, you're mindful again. It's that simple. It's always just one moment of awareness away. All right, so I asked you to create a speed bump. Did anyone do that? Did anyone remember to do that? Right? Okay, that's why you have to create the speed bump. The physical cue, dividing your food in half, either half a sandwich or a line on the bowl of soup or whatever it is. Because if you don't have that physical reminder, you will go back into autopilot, because we've done that a million times before. Now, satiety is your body's signal that you've had enough food. If you feel uncomfortable after you're done, it means at some point you probably checked out and you didn't notice that you were becoming overly full. Now, for many people, it takes about 20, 30 minutes. Be curious about that for yourself. How long does it take for me to feel as full as I'm going to feel after a meal? But for most of us, there's a delay, because fullness is not just physical fullness. It's also an entire biochemical process that happens. But satiety is also not just physical fullness, it's enjoyment of food too. So all of this ties together, and mindfulness will help it bring together. If you feel overly full when you're done eating, it doesn't mean you failed. It doesn't mean you should be ashamed. It just means that somewhere along the line, you missed something. And what can you learn from that? So I don't have time to do it, but when I'm coaching somebody and they tell me about an episode of eating, I will literally draw an eating cycle. And as they're telling me the different components of the episode, I will write them down next to the decision points. And then when they're all done talking about it, then I will repeat back to them in order. They don't have to tell me the story in order, but I will repeat back to them how the thing went and fill in any gaps, ask any questions. And then I'll ask them, okay, so why do you think this happened? And then once they have some insights about it, then I'll say, okay, when this happens again, this situation happens again, what could you do differently? And they will literally recreate the eating cycle with a new pattern. Make sense? Okay, very practical. All right. Last, where do I invest my energy? So where you invest your energy in our culture is very much about exercise. You know, you eat this amount, you have to exercise this amount. And of course, the math never really works out in your favor. So people end up going, why bother? I can't burn off my 4 donuts, so I'm not even going to bother, right? It turns exercise into punishment for eating. And in my practice, when I was still practicing family medicine, people go, you know, Dr. May, I know I should exercise, but I hate it. When I'm hearing should and hate, I'm pretty sure that we've created this sort of an association. And so ultimately, and I'm preaching to the choir here, I know, ultimately, where you invest your energy is about your entire life. It's about body, mind, heart, and spirit. And doing the work that you do, and I think we can talk about this during our panel discussion, but how do you help overcome exercise resistance is a big piece of this puzzle, because a lot of times people have learned this other way to think about movement. All right, so this is a ongoing process. It's something where we are literally allowing our lives to unfold before us a moment at a time. And, weight is not a behavior. If we're going to focus on behavior change, lifestyle change, we have to literally focus on choices. Choices are made in the present moment, which is what mindfulness is all about. So mindful eating offers us an ability to literally drop into the present moment, teach our patients and clients how to do that so that they are learning from every mistake, every opportunity, every decision that they make. All right, so I'm going to wrap this up here. Whenever you feel like eating, pause, check in, and just notice, am I hungry? Am I bored? Am I stressed? Does this look delicious? Have I been depriving myself of brownies or whatever the situation is? And the second piece of this is to set your fork down, because mindfulness is about being in the present moment. And when we're loading that next fork full of food, we are not paying attention to the one we're eating right now. And for many of us, got a lot of high achievers in the room here. For many of us, we're living our lives like this too. We are rushing through the present moment thinking, well, when my kids are finally in school, then I'll have time to, start yoga. Or when I get through the week, then we'll relax on the weekend. Or I can power through this, and then during summer break, I'll take a vacation or sleep in. Or when I retire, then I will finally get our life is literally passing moment by moment. This is your life, and I would highly urge you, invite you to put your fork down and be present for what's happening right now, because your life is not out there. It is right here in this moment. So I really appreciate you allowing me to share this moment with you, and I hope you learned something valuable and very practical for yourself. And if you're interested in talking about it, you can reach me at training@amihungry.com. I'd love to have a conversation with you. This link here will take you to a bunch of free resources, one-page downloads about a lot of the things I talked about, and some health professional slide decks and things like that. So if I can do anything for you, let me know. Thank you. I'm on a panel in a bit, so in order to help us get back on schedule, I'll skip questions now, but bring them to the panel if you'd like, okay? Thank you.
Thank you, Michelle, for an inspiring presentation. That was fabulous. I'm still hungry, though. I'm going to come back and finish lunch. Anyway, I am delighted to introduce our next speaker, Dr. Brian Kinslow, who is a licensed physical therapist and distinguished graduate of Northern Arizona University's Doctor of Physical Therapy program. He is the co-owner of Evolve Flagstaff and specializes in orthopedic diagnosis, running and walking, and gait analysis, the integration of physical therapy and strength training, and conservative management of orthopedic pain and injury. Brian practices with a health at every size approach and works with his patients to improve their overall health and wellness as well as their injuries. He has over a decade of strength training experience in addition to physical therapy, and is passionate about helping people to resolve pain and stay active throughout their lives.
All right. Hi, I'm Brian. Thanks y'all so much for coming. Also to Abby and Michelle for an amazing start. Hopefully what I have to say kind of parlays nicely off of that. Excuse me one second. But I'm going to talk about exercise. We talked about nutrition, mindfulness. And so here we're going to talk about a weight neutral approach to movement in healthcare. So we're talking about how maybe we reframe this. What if exercise, physical activity, movement wasn't about our weight? That's the world we're going to try to envision together. We're going to review just what the guidelines are and why the guidelines are set up in the way that they are, and then build a framework to hopefully help patients establish a consistent routine. Just some disclosures. I don't have any financial disclosures. Like Abby kind of set up disclosures of privileges. I am who I am. Kind of looked similar since I was probably about 2 years old. Look at photos. I've kind of been the same regardless of the amount of physical activity I have or haven't done. I've been in a similar body size, always pretty average height, and skin color is what it is, and that affects my worldview and my experience. So what we're going to talk about today is based on some of my experience, but also the research evidence and my clinical experience. I'm a doctor of physical therapy. I'm Abby's counterpart at Evolve Flagstaff, where we offer one-on-one physical therapy, dietitian counseling, and we have a whole gym and fitness component. And just it's kind of a side note, we often in recent years struggle to describe, based on who we're talking to, what we actually do, because so many of the terms have been co-opted by fitness and diet culture. So health, even that can be a tricky term because health often means weight loss. The term holistic sounds kind of nice, but that can also mean somehow something to do with weight loss. Cohesive, functional, so kind of a lot of these terms. But what we try to do is help people get where they want to go and live the most vibrant and engaged life possible. So hopefully they don't take some of those terms from us, but we'll see. So Abby took a little of my thunder here, but is anybody a pharmaceutical provider in here? Anybody licensed? Okay, I'm not either. But we had one pharmacology class in school. And so would we prescribe this drug? Less than 20% efficacy, depending on the study, as low as 1 to 3%. Less than 5% average change in the desired outcome after a year. High risk of severe lifelong side effects, including the second deadliest mental health condition, along with osteoporosis, falls, fracture, sarcopenia. And it's going to discourage future participation in health promoting activities. Yeah, it's a great drug, right? Not so much. So, but that's what happens with weight loss and with exercise or physical activity and weight loss. And I'm going to be using the terms exercise and physical activity interchangeably, just as kind of common parlance, but in the research, they are a bit different, whereas physical activity is kind of any movement, exercise is a little more structured progression. So there's a whole semantic reasons for that, but I'm going to be using those interchangeably today. But we're going to have 6 steps to a weight-neutral approach to exercise. Number 1 is we have to craft a new narrative, understand what barriers might be for ourselves, as well as for the folks we're working with, collaborate and troubleshoot with those folks. We're going to try to keep it simple, especially if somebody is starting out or has been inconsistent in the past. To set the right goals and expectations. And then after some amount of time, we want to reassess and potentially progress or change or tweak the routine. You notice about those 6 steps, that's kind of what we should do for everybody, right? And so as I was putting this presentation together and was talking with some of our staff yesterday, I was like, yeah, it's kind of like actually how to create a good physical activity routine for anybody. We just tend to treat people who look a certain way a little bit different. And so regardless of the size of your body, how you look, how you show up in the world, these steps should hopefully be helpful. So I saw this term actually just last week, polypill. I kind of liked it, but exercise is a polypill, meaning it affects every cell in the body. And so I'm not going to go through all of the benefits of physical activity today because most of us know that. I've never met a person who comes into my office and doesn't know that in some way movement is good for them. But cardiovascular exercise and resistance training positively impact over 40 different chronic conditions or diseases. They improve longevity, which is also a charged term now, but we'll call it how well you live and how well you live as you age. They decrease healthcare spending, and most importantly, they let you hopefully engage more positively and fully in your life. And all of those benefits are independent of any change in BMI or weight. Independent, so we can have all of those benefits without anything dropping. And just as a side note, a patient who's just fresh on my mind, I worked with her twice this week. She's in her early 60s, and we're trying to figure out an exercise routine that works for her. The problem that she has had is she is at a high risk of falls. I'm not quite sure why. I think there's actually some psychological trauma in her background that has affected how she processes kind of movement and her motor skills, but she's had 10 falls in the last 5 years, including fractured ribs several times, fractured wrist, fractured elbow that required surgery. So kind of high risk of falls, has osteoporosis, but she's very thin. And she came in just yesterday and said that she had gained a pound. And that was what she was most worried about. And it just kind of both broke my heart, and we had to have a conversation. It was, I think we navigated it well, but I said, I'm really most concerned about your falls and how we prevent that. And it led to a good conversation about what she was, getting out of that. But she had been indoctrinated for her whole life to the point where it's now going to affect, our potential rehab plan. And so when we talk about exercise as a polypill, we also can't do that if people aren't eating enough, because I'm thinking now today after hearing Abby Michelle talk, maybe she's falling because she's low blood sugar. And so I don't know, that's something I'm going to screen. And so there's perhaps no powerful, more consistent medicine for us, but it's not actually going to work if we haven't had the fuel to sustain our bodies as we do that. Yeah. So Pierce says fitness is what matters. And so there's a really fascinating set of studies. There was a new meta-analysis, a systematic review and meta-analysis that came out on 2024. It's kind of a follow-up to one that was done in 2014, I believe, or 2013. And they were looking at cardiovascular disease mortality and cardiovascular fitness, as well as BMI. And what they found is that it wasn't the BMI or body size that mattered. Individuals who had higher levels of cardiovascular fitness had decreased all-cause mortality across the board. And there was 2 to 3 times decreased cardiovascular risk, and that was uniform no matter what BMI size you were. And so the quote there I put on is, once cardiovascular fitness was accounted for, there were no significant increases in all-cause mortality or cardiovascular disease mortality for individuals in overweight or obese BMI categories. That's surprising to anybody based on the common narrative? I say no, I've seen some of this one before. Yeah. And then strength is also protective. Undertaking any amount of resistance training, I think this was over like a month period, I forget the exact number, but any amount of resistance training reduced all-cause mortality, cardiovascular disease mortality, even though we're looking at muscular exercise, and actually cancer mortality. And there's more and more research coming out about the effects of resistance training for a whole vast different types of cancer. And actually some of my graduate research as part of some studies in grad school looking at the effects of physical activity for cancer recurrence in cancer survivors. And so the research there is really fascinating because it's not one that we would think, why would physical activity affect prostate cancer risk or stomach cancer risk, but almost across the map, pretty much every type of cancer, as well as mental health, cognition, orthopedic health, and on down the road. And so again, these are independent of changes in weight. So how much do we need? And so these are the public health guidelines, or at least kind of a slight reinterpretation of them. So generally, we want easy movement throughout the day. So we want to break up bouts of sitting, getting our, there's debate over does 10,000 steps matter, does 8,000 steps matter? But the gist is we want to be able to move around. Humans evolved as bipedal creatures, evolved to walk if walking is possible for you. There's actually, all-cause mortality benefits. Every kind of 1,000-step increase, we see a reduction in all-cause mortality. And then working in some balance. Flexibility is kind of a question mark for me as a physical therapist. Sometimes I think it's sometimes a bit overemphasized, but if we're super rigid and stiff, or if I've been sitting for an hour, then yeah, maybe I want to do some light flexibility work. Aerobic exercise, the guidelines usually are phrased as 150 minutes of moderate intensity exercise, or 75 minutes of vigorous exercise, or a combination, and you can add them up and multiply the vigorous by 2, and it's like everybody's like, oh, what does that mean? So I say, let's get 2 hours a week of moderate intensity, and I'll talk in a bit more about how we gauge that, and 20 minutes per week going a little bit harder. If you have a preferred style that's more one or the other, then we can probably fit that in there too. And then resistance training, that's where I live a lot of my time, is working with people on resistance training routines to prevent or reduce the risk of injury, or as they're coming back from injury, or to support the things they want to do. But really the guidelines there is that we can get optimal benefits if we structure it correctly at just twice a week, with sometimes as short as 30 minutes, up to potentially an hour. And so usually the patients that I see coming in when I'm talking about resistance training maybe have a whole different view of what that might be in their mind. And they often think we're trying to turn them into gym rats, where they're in the gym every day for hours and hours. And we can be pretty efficient and get a lot of the benefits out of it. So those are the guidelines, and they're based, when you read into the research of how do they get to this, there's different kind of ways in which it's done, but they kind of take a review of all the literature and look at what is the dose response. And so in general with exercise, we get a dose response up to a certain amount where more is helpful. But they find at these levels, we get a pretty optimal benefit across wide variety of body systems. There might be a little bit more benefit for some additional aerobic exercise, not a whole ton for additional resistance training, maybe a touch. And then easy daily movement, as long as you're sleeping and recovering well and eating enough, easy daily movement throughout the day. It's hard to put a cap on that, as long as you're not doing it at the detriment of yourself or as punishment. But any amount helps. And so one thing I think is important as we go through today is that falling short of those guidelines should not be seen as a failure. Life is life. We're all humans. And also, if somebody has not been active, I'm not going to start them at these guidelines. We're going to start probably way short of those and work up gradually, because it's really consistency over time that matters. Familiar with the term lifetime exposure? So it's often used in terms of harm. So lifetime exposure to secondhand smoke, lifetime exposure to higher cholesterol levels. I've started to think about that with exercise in the opposite direction. It's really our lifetime exposure. So it's consistency over time that I think is where the benefits are where we really see some of that. And so just an hour or two a week of moderate or vigorous activity reduced all-cause mortality by, depending on the study, 18 to 31%. Just 3 one-minute bouts of vigorous activity improved all-cause mortality by almost 40%, which is kind of wild. And just one set of resistance training exercises, just one set, but hard, performed to fatigue, can improve strength. And this was in, I think, adults over 65. So a population that we thought maybe couldn't, or is challenging to gain strength. So any amount helps. And so I think that can be a big message either for you or for folks that you work with. And I guess I'll also say as I move on is I want to support people being active in a way that makes sense for them. Something that doing work in this space challenged me early on as a provider is that if folks don't at this moment desire to be healthy, I shouldn't try to force them or guilt them or shame them. And so people tend to come into my office because they want to make a change. They want to get over something. But if people, it's like they have different priorities, if they have different goals, if, I can think of a lot of reasons for me why it might be helpful to be active. But I think it's important that we don't impart our own value, our own belief system onto somebody else. So cycle of inactivity, actually similar to kind of a cycle that Shell talked about and Abby talked about. So there's a lot of parallels between nutrition as well as physical activity. But what we often see is at the beginning, people have high motivation. Something happens, something's changed, and they're like, okay, this is going to be the time that I'm going to be consistent. But maybe they have unrealistic goals or expectations. I usually say, usually it's when I ask, okay, how much time do you think you could spend? How many days a week? People are like, oh, I got 6-7 days a week, about 75 minutes easy. And I'm like, what have you been doing recently? And they're like, no, I haven't been doing much, but I can do that now. And I'm like, okay, let's go 15 minutes one day a week and stuff there. And so people, when they're motivated, and I love the optimism in most of humanity, is that they think they can do it, but it might be an unsustainable start. And then there's some disruption. Maybe it's pain or injury, a scheduling conflict, a child gets sick, but also they're maybe not seeing progress, whatever progress means for them. Maybe the routine that I gave them, that another provider gave them, was too complicated. They start to feel overwhelmed, and feelings of that they can't do it. A lack of self-efficacy is one of the biggest things that shows up as why people stop an exercise routine. And then feelings of judgment from their provider, judgment from somebody else that they see in the gym environment, judgment from a friend they're walking with. I had a patient, this was a couple of months ago, but we were having a hard time calming down her knee pain. And as we started to dig into it, she would flare up her knee pain every time she went to walk with a friend who she perceived was way more fit than her, perceived, I don't think the friend ever said this, way more fit than her, wanted to walk faster than her, and would get frustrated if they would wait. And I asked, and she never actually asked the friend if that's what it was, but it pushed her into a way long walking stride, walking further than they wanted, not being able to sit down before pain started. And so, we had probably way more PT sessions than we needed because she had these feelings of judgment that may or may not have been real, but they were definitely running through her head. So unsustainable start, some disruption, and then we give it all up. There's an all or nothing mentality. And that's sometimes the challenge that I have when I suggest a simple plan that is not very time consuming. Some people don't want to do it because they have this all or nothing mentality where they're like, well, that's not every day. What is that going to do? And so that's why every little bit counts, I think, is a really important message, because having an all or nothing mentality, nobody is perfect all of the time, and life happens. So having a backup plan, knowing that every bit counts, can help you hopefully not abandon the routine entirely. And then we have guilt, shame, feeling of failure, feelings of regret, tensions to try harder next time. It's the same cycle that we see in dieting from a nutrition perspective. But then also guilt or blame from healthcare providers. I'm a physical therapist, and I've heard from other patients, they're both afraid of getting a guilt trip from me when they come back and say they haven't done it, or they report that they've had healthcare providers tell them, they call and say, hey, I didn't do my exercises. Should I come in? I'm like, of course. But they're like, yeah, my last PT didn't want me to come back if I hadn't done the things. It's like, what kind of a professional is that? And so I hope that doesn't happen too often, but I have heard of that happening. So there's guilt and shame, and then probably not much until something sparks a new cycle. So this is real, and I see it every day. So our hope is that we can reframe exercise to break us out of that cycle. So we're going to craft a new narrative and work from there. So how do we craft a new narrative? And so first, understanding, the research is very clear on this, that attempts to establish a consistent routine are less successful when weight loss is the goal. Study after study has shown that. And so when that is primary, we're setting the person up for failure potentially at some point. And the research suggests various reasons for that, but usually it's that the progress will stall at some point, or it's not a behavioral measure, so it's an outcome measure that's very multifactorial. It leads to their reinforcing, potentially, if that's the goal, how people might be judging them if they haven't gotten there as they go into a fitness environment. So our new narrative, and this can go back, there's different ways to phrase it, but I think about function, participation, and health. And this depends solely on what the person is telling me. And if they don't have any ideas other than weight loss, then I might start to gently suggest some things. But function, that's kind of like our activities of daily living. And there's going to be overlap in all these categories, but carry groceries, up and down the stairs, walking your dog, cleaning the house. And there's participation. So that generally is things with other people. But coaching a child's sports team, playing with your grandkids, going for a hike, traveling. And then other health markers, blood pressure, blood sugar control, cholesterol, cognition. And again, all of those things can be improved without any change in BMI or weight. I miss anything? What else could be a reason to be active other than weight? Yeah.
Mental health.
Mental health, 100%. Yeah. Yeah, some studies show that the power of exercise can equal that of an SSRI. So don't go off your SSRI, but exercise should be a frontline treatment for mental health conditions. Yeah, Brent.
Use for coping skills.
Yeah. How so? What do you mean?
So like people with substance use, they use exercise as a coping skill.
Yeah. Yeah. So we often will, people will say that it's helpful for their mental health or other reasons. Tell people I don't want it to be only coping skill, because then we're going to run into an overuse injury, and what happens if that's the case. But just like we can eat for various reasons, we can exercise for various reasons. That can be a great thing.
Being in community and hanging out with friends.
Hanging out with friends, being in community. Yeah. Having fun, being playful, using our bodies. Yeah. Joy.
So, because I've always exercised, and to me, it's like, well, I want to be able to do all these other things. Like if I can't reach things in my closet because my arms don't work, or I can't handle being on a plane and going on a trip or something like that. Like it's these other things I want to do that I want to have the capacity. So it's building that capacity.
Yeah. Love that.
So I think pain, right?
Yeah.
Where you do this exercise, because if I do this exercise, the thing won't hurt as much.
Exactly. Yeah. That's the root of a lot of physical therapy. Yeah. And there's kind of a book that, made a lot of media splash in the past year or two. There was a lot of diet culture elements in it, so I didn't love every piece of it. But one question that was in this book, it was on longevity, was, what are the things that you want to be able to do in your last decade of life when you probably have the most time and potentially, financial resources, depending on how your career progressed or whatnot. But to me, that was a powerful question. What do you want to do in your last 10 years of life? We know that with good movement, good exercise, we can delay a lot of muscle loss that we didn't think was possible. But we're going to start to lose some strength, some muscle, some bone, no matter how much we train. And so the more we have in our younger years, the more kind of buffer that we have. Yeah, exactly. So don't want to scare people, but that can also be something to help get people thinking beyond the scale. And that kind of leads us into barriers. So hopefully we're creating, maybe with the person we're with or ourselves, some excitement of like, oh yeah, I would love to be able to do that, or I'd love to have fun in that way. And I can't right now, and can I train for that? But there's a ton of barriers out there, and these are not going to be all of the barriers, but pain or injury, time, lack of support can be a big one, scheduling and prioritization. I think that's a little different than time. That's kind of maybe you have the time, but you always will put other people first, or kind of organizing your day in a way that you can make it happen. But then judgment or feeling unwelcome, I think is one of the biggest ones in a lot of fitness environments. And that can come from a lot of ways. It can come from the words that we use, the imagery that we use, even the way that we describe exercises can impart feelings of judgment, or feeling unwelcome or less than. and also no clear progress. And so in a few moments, we're going to talk about how do we maybe choose some different goals. But when people feel stuck, they're more likely to abandon it. And if we don't have a way to help redirect what progress looks like, we're going to be less likely to continue. And then there's movement selection. I see people every week who come in thinking that to be active, they have to run or they have to do some weightlifting movement that they've gotten injured with in the past. And so they're like thinking they can't be active because they have this rigid view of what it should be, or the exercise they prescribed aren't right for them, or where every body shape, size, and ability has exercise that may be better suited to them. And so, so are they comfortable getting up and down from the floor? Maybe that's something we would want to work on, but if they're uncomfortable with it, maybe not at first. Up and down from a flat bench. I had an individual about 6 months ago where I probably made a mistake, but I put them down on a flat bench to do a chest press. It went great. And then they did not have the core strength to sit up. And it was really, the individual was, I could tell, felt embarrassed. I felt like bad, like I should have, kind of not walked into that one. And we were able to redirect and but I assured him we do not have to do that exercise, because it seemed to be in that moment, if we had to do that exercise, he was not coming back. And so I did, various times do different things where we were standing and, convince him that that is not an essential exercise at all. And so I'm not perfect, but those are the types of things that I think sometimes we don't even think about when talking about exercises. Is that going to make a person feel like they don't want to come back? I had another individual who was coming to the gym fairly consistently, and we didn't see him for several weeks. We're always a little careful when we check in with people that we haven't seen. We don't want to be a gym that makes money off people paying and then not coming, but also we don't want to make people feel guilty if we don't see them. Anyway, I came back and we're like, hey, how's it going? Where you been? Or what's going on? And he said that we had some exercise where we're doing like a hurdle step thing to work on some dynamic balance. And he was like, that reminded me of high school football where that was a punishment. And I just couldn't come in, as he said. I was like, oh my God, like that is not an essential exercise. There's a ton of ways we can work on that. But that's just something we didn't know. I don't think he knew it until it somehow brought something back up in him. So, so just always checking in on how things are making people feel comfortable. And then complexity and self-efficacy. So there's some barriers. I'm sure there's a ton more. Any other barriers that folks can think of? Yeah.
I think about the economics, the money, because, well, some people live in neighborhoods that are not safe, so they can't go for a walk.
Yeah.
They don't have the money to go to a class or belong to a club. And it also might mean that they're working 3 jobs.
Yeah.
And so how do we get, I always like the word activity, like some of the things they may be doing, they are doing activities that, we can talk about it that way. Like, how is that activity that you're doing that's positive for you, and work it into your job or whatever?
Yeah.
Yeah.
Yeah. And that's where I think, as a provider, if you're working with exercise, being able to be creative and problem solving, you might not know the answer, but if it's something where it's like, it's okay if you're here all day and at working 3 jobs, can we just do a little bit of this at some point with a resistance band that doesn't cost very much? Or so troubleshooting and sometimes we run into issues where it's like, ooh, life is tough sometimes, especially in various parts of the country and in various parts of our town. And so, so being aware of that before you recommend something, I think will help. Here we go. Dawn, we'll go down.
I bet you were going to say the same thing. Weight stigma would be a big barrier for folks. And you think about gym culture and not having representation of different bodies from employees at gyms, posters on the wall that don't represent all shapes and sizes. Like, how do we make gyms more welcoming to people in different bodies?
Yeah, for sure. Mirrors in fitness facilities. There's sometimes like a motor control reason why you might want to have one somewhere, but generally having walls full of mirrors makes it very body image focused, or having, pictures of shirtless bodybuilders all over the wall.
I've read some research that there is a genotype where the responses to exercise are actually uncomfortable. And so those patients won't exercise because they interpret that as danger.
Yeah.
And I just wonder if you've seen that in your practice.
Yeah. Since I have heard of that, I don't know the prevalence of that, but a similar thing can happen with chronic fatigue syndrome, long COVID, different autoimmune conditions, mast cell activation syndrome. They can have an adverse response, post-concussive syndrome. And so I think being attuned to that and getting a good history, especially if they're engaging you as a healthcare provider, and kind of knowing your dosage and intensity levels. Yeah.
I think one is like the excitement of it. I think right now, there is an aspect where within like fitness and all of that, it's like it is this aspect of entertainment. And so I think people are like, well, I should always be having a good time and like you shouldn't be suffering by any means. But then I think people are like, well, it's not like all of these things, so I don't want to do it. And so I think there's this balance of like novelty and keeping it fun so people want to do it, but it also not only being that.
Yeah. Yeah.
I think what comes up a lot, and it's to Dawn's point about the weight stigma piece, is the access to clothing and bathing suits. I've had clients that really want to swim, but going even to buy one or having the financial ability to go buy new things that, and online and social media, the cute outfits, and it's very much like an aesthetic look too. So I think that's a lot. That one's funny.
Oh, good. Yeah. I think there's a ton of barriers, especially around weight stigma. I have some things in a bit on how we might tackle some of those, and I'll look to some of you for how things I missed on how we might tackle them. But there's a lot out there, and there's probably a ton of other things that you might have no idea are running through somebody's head as we're talking about movement and exercise. And so being curious, asking questions, helping to troubleshoot, and kind of coming up with something together rather than just kind of saying, here's the guidelines, go do it. I think is a really important piece. Yeah.
I have one last thing on that too, kind of building on what Ashley mentioned, but even in like a typical gym setting, say, there is like a leg press machine or something like that, those are again fit for a standard body. And so if you can't fit in them, then you're like, well, this place isn't for me.
Yeah. Yeah. There's times where machines can be more accessible for individuals in different body shapes and sizes, and sometimes a lot less accessible. And so knowing what the environment is like, yeah, it's really important. And one more that's not on here is I don't know the exact thing, but I believe there was a study. Somebody can fact check me on this. Humans have mirror neurons, right? And so somebody watching videos of exercise makes them less likely to actually go do the exercise. And so asking if somebody has a trouble, they're like, yeah, I got all my stuff ready and I was going to go. I'd be like, well, what did you do after you got your stuff ready? And so that one I think is kind of interesting, but yeah, social media, I think it has to be perfect. I think you have to have the right outfit, and knowing that physical activity can look like almost anything as long as we're moving our body. And so some questions that I ask, and I'm sure you all have some others, but what has been hard in the past? What can we be sure to avoid? Is there anything that has tripped you up that you know about that we want to avoid? After that guy who had that experience with the agility drill in football, I ask people every time I've said my exercise program, like, is there anything you really don't like doing? Not because it's just hard, but because there's just something about it that you dislike, even if you don't know why. And a lot of times people aren't sure, and I'm like, and sometimes I'll tell them why I'm asking that. And I say there's no exercise that we have to do, so I want to make sure we avoid any pitfalls that we can identify in advance. And then just asking, before you recommend anything, what support can I offer you to help you be successful? What would an ideal routine look like? If they're working 3 jobs, but they know that some additional type of movement might be helpful, be like, where might we fit that in? What's worked well in the past when you felt like something was working well? Why did that stop working well? And then if you're I always think this is a motivational interviewing technique, is asking permission to advise, even though they're walking in your office probably for help, being like, well, I have some thoughts on that, but is it okay if I share those? Or yeah, and I think that can get that can go a long way to creating an alliance with the person you're working with. And just as a side note on pain, is I don't think that weight loss is a valid, evidence-based, or even helpful, even ethical pain reduction strategy. And why is that? And I say this, I have this here because pain can be a barrier to movement. But if somebody goes in with knee pain and they're told to lose weight, well, what do most people know about how to lose weight? Diet and exercise, right, is what we're always told. And so suboptimal intakes increase our risk of chronic pain. So it can sensitize the nervous system to interpret stimuli as more painful, and that pain is real, and it can be hard to unwind a nervous system that is sensitized. They also slow healing. If there's a surgical scar that needs to heal, we need a lot of intake to heal that. So suboptimal intakes is not helpful for healing or for pain. Weight loss is almost always associated with muscle loss, even in quote unquote ideal conditions where they're pumping people with protein and on a resistance training routine. Most people aren't on a resistance training routine or eating enough when they're trying to lose weight. The patient I had who has osteoporosis and fractures, he's going to lose bone density. And then if movement hurts, how is that advice, often given by somebody who doesn't have time to troubleshoot, how is that advice to go move around to lose weight going to even be helpful? And it has less than 20% chance of long-term success. So I think that's an unethical strategy when somebody walks into an orthopedic office or a physical therapy office or anywhere and say, I have pain. It's like, oh, go lose a little bit of weight. And as a side note on often it's in terms of osteoarthritis. So osteoarthritis is cartilage loss is one piece of it. Often you see an x-ray and that probably like, that's bone on bone, that's not good. But what we know now, which we've known for, Jay, you might correct me on this, maybe 20, 25 years at least, is that it is a systemic condition. The cartilage loss is one piece of it, but then it gets sensitized by the rest of our body, lack of sleep, suboptimal intakes, systemic inflammation, type 2 diabetes increases risk. So we can have people who have what's called bone on bone, but have no pain and full function. And then we have other people who have very little cartilage loss, but have all the symptoms of osteoarthritis. And so, and also the connection to just biomechanical loading to me is actually a little shaky. We sometimes see there's some studies where in osteoarthritis where there's weight loss and good outcomes, meaning less pain or better surgery recovery. But what's always included in those studies is physical activity and exercise. And so what is causative in the scenario to me, given what we know about weight loss, I think it's all the other things they're doing. And so there's a really good series on this that I'll share that'll be included in some of the resources where they break down some of the osteoarthritis research and look at, even in some of the studies, they are looking at physical activity, and then in the conclusion they're like, weight loss is helpful for osteoarthritis. You're like, the study didn't even look at weight loss. It's kind of interesting, but running can cause knee pain. But a study came out a couple of years ago that lifelong runners have better joint health, better meaning looks better in x-ray and less pain, than non-runners on average. Running puts, depending on the terrain and speed, anywhere from 3 to 7 times your body weight of force through your leg. What the research calls successful weight loss efforts long-term is 10% sustained. And so if we think of running as 3 to 7 times body weight through your leg, how is losing 10% biomechanically, is that making actually a really big difference on the joint surfaces compared to an activity with a ton of force that in some circumstances can cause pain, but usually there's other reasons for that, training load, progression, maybe some biomechanics. And so the connection between even the biomechanical piece to me is a bit flimsy as we apply just a different slant to how they're looking at it. So anyway, that's kind of my physical therapy side note on pain and osteoarthritis. But if somebody has a barrier of pain or injury, get them to a provider who knows how to potentially help them without a focus on weight loss, and restore their movement in a way that feels right for whatever is painful, but can support the rest of them as well. Any questions there on kind of pain, injury, stuff like that? All right.
I just want to express gratitude to you, Brian, and to think about all the people in PT and orthopedic surgeons who don't know what you know. So please, whatever you can do to get the word out.
We'll do our best. Well, thank you. And I would say, and sometimes I run a hypothetical, or Abby and I do, is that it's like, well, what if it was weight loss that was a causative thing? Well, how do we even get there? Well, we're not going to shame the person. We're going to do all of these things that we're talking about today. But we know that that's not the world we live in. So let's just leave that aside and focus on the behavior.
And we got a comment from Aura online, said, I would add misnomer and intimidation of women in the gym by the serious weightlifters.
Yeah.
Good point, Aura.
Yeah. Yeah.
25-year-old man coming mansplaining.
It's the worst.
By your physical therapist. I
Yeah.
compare you, I've got my ear.
Oh. Yeah. Sorry that happened. Yeah, so there's a lot of barriers out there, and this kind of ties into that. And these are not the only collaboration strategies, but some common pitfalls, I think, are the equipment. So free weights can be more adaptable to different body shapes and sizes, but they often require a bit more instruction, and there can be a financial barrier to either purchasing them for your home or going to a facility. Unfortunately, we don't have a lot of free fitness facilities around. Machines, they can be more an easier entry point because there's less motor control elements. The technique is a little harder to screw up, but they're not right for every body size. And I don't mean just kind of larger bodies, smaller bodies. It can be a height difference, a shoulder range of motion thing. And so machines there's two sides to that coin. Mini loop bands, so like kind of mini bands that often PTs will put around the knees. We have a ton of them in our facility, but I have learned through trial and error, mostly error, that a lot of people don't like those because they don't feel good. They're hard to put on. They can cut into skin. They can roll up. I've had people break them. They're hard to do. But they're a common thing. And so thinking just how is the person going to actually use this equipment, and can we set them up not to have a challenge with the equipment? And so if we actually have some that have a buckle on them. So if we feel like that's an important thing that we want to do, there's fairly inexpensive ones that are fabric, they feel better, and they have a buckle. And there's one company out there that actually sells them in different diameters for different leg sizes. So thinking about the equipment, and then also, there's a lot of cheap stuff online that can be great for somebody who wants some equipment at home that's inexpensive. But when running a facility, if you are, make sure your stuff's supportive, stable, durable, not just from a safety element, but when somebody looks at it, they know that it's right for them, and that it's not, that they don't feel like it's unsafe or going to move underneath them. And then exercise selection, we touched on this a little bit, but making sure it's something that's right for them. But also, we'll go into this a bit more as I talk about how to design a resistance training routine. I like to frame exercises in terms of function rather than aesthetics. So I still think a lot of resistance training world comes out of bodybuilding. Bodybuilding was kind of the first real, foray into resistance training through like the 50s up until the 90s. There's a little bit of like Olympic weightlifting and strongman and circus stuff on the edges, but really resistance training came into the public eye and into research through bodybuilding, which is muscle by muscle approach. And even physical therapy, we think like that in a lot of ways. But humans, I don't use my anterior fibers of my deltoid for anything. I lift my arm. And the motor cortex has a hard time, I can't distinguish between the different flexor tendons of my finger. And so there's times as a PT, I might want to isolate a muscle for a specific reason. But if somebody does not have an injury, I'm going to frame all of our resistance work in terms of how can we move. And so I think getting away from aesthetics and how we describe things can be an important piece that helps to make somebody feel at ease, that we're not actually looking at how their body appears, we're looking at just things that they're able to do. And then the environment piece is a big one. And that one I don't have an easy answer for, because facilities can be great, but they can be really uncomfortable, intimidating, scary, or actively damaging. Home can be okay, and the research actually disagrees with me. The research shows that home plans can be sustainable long-term. Anecdotally, this is my anecdotal bias, they often fizzle or they're hard to progress. So again, there is some research to show the opposite. But if somebody's doing stuff only at home, I want to check in and make sure that we're actually getting what we want done and that they're able to do it safely and effectively. And if you are running a facility, make it known often and loudly that everybody is welcome. Don't just have that as a part of your mission statement somewhere on a part of the website nobody reads. Okay, only got a few minutes. So I'm going to go through some things. How do we design a program? We want to keep it simple, especially at first. And something we say all the time at our facilities, consistency before intensity. And so the activity pyramid here is a frequent daily movement first. And then we want to get out of breath and use our muscles, even if it's a really small dose. If that's going well, then maybe we'll progress to meet those activity guidelines. For a lot of people, that might be where we stop. But then if somebody wants more, then we'll add a little variety and complexity, and then maybe they train for a specific thing. I don't have any problem with somebody doing like, hey, they haven't been active, they want to sign up for a 5K. Like if that's somebody who comes in with, that's great. But if somebody says, hey, I haven't been active, I don't know where to start, do you think I should train for a running race? I'm like, let's just start with something that's simple, and then we'll get into some sports-specific stuff down the road. And when we do that, we need to keep all of those things. Most of the runners I work with have some component of their injury where they abandoned resistance training. That's a big generalization, but probably 80–90% of the runners I work with either have never done resistance training or they get into running and it falls away from their routine. And so if we are doing sports-specific training, or same with powerlifting, I see it the opposite. They stop doing aerobic stuff. So we want to have a comprehensive routine, even if we're doing a sport. So aerobic exercise, any modality works. So find what's comfortable, find what's accessible, find what feels good. If we are progressing to these guidelines, I want a fair bit of time at a moderate intensity and a little bit at a high intensity. There's different ways to measure this. There's often something about singing, something about a talk test, a heart rate max. I've had people go, well, I don't sing. How does that, I don't know what that means. And so one that I like is moderate intensity is out of breath, but you could talk. It might be a little annoying to be on the phone with you, but we could do it. And high intensity is like, you can maybe say, hey, I'll call you later, and then you click. So that's different ways to look at that. Heart rate, if you're on certain medications like beta blockers, isn't always the best gauge of intensity. And then resistance training is a lot more complex. This could be a whole day, a whole weekend, a whole semester, but we can keep it simple. And the research shows this. There's actually a paper I have in the references. It's something called like that we need to move to more uncomplicated guidelines. And so a researcher called Brad Schoenfield, who does a lot of research on actually like hypertrophy for high-end kind of bodybuilder type things. He also does some public health research. And he had a paper where they looked at minimum we can do once a week or potentially twice. He recommends, if time is the essence, we choose 3 exercises, but we have to make them challenging. And so there's different ways to look at it. From a function standpoint, I started thinking about it for our legs. We can drive up, so I can go upstairs, I can pick something up, I can push something away from me, and then I can slow down. I can kind of have to lower my body weight, control things in gravity. Those aren't perfect delineations, but it sometimes can help frame things. Upper body, I can push and I can pull. I can do that at various angles. And then the core is often a triggering one for people, or anytime I ask people for feedback on workouts, I think because of diet culture, they say, yeah, we need more core in there. I'm like, yeah, kind of a lot in there, but okay. So I stopped asking some of those questions. But I think what do the torso muscles do is I can carry things down here, up here, one hand. And then generally these are stabilization muscles. Most athletic movements, it's actually that this stays still. And so that's how I think about the torso muscles. So we pick 3 exercises a session, find ones that feel good. If you don't want to make this your life, you don't even have to change the exercise that often, but find a way that you can progress it to make it hard. A simple guideline is if you can do more than 15 reps or more than 60 seconds, let's add a little bit of resistance. The research does show we can get progress with 20 or even 30 repetitions, but it has to be like pretty close to failure. Most people actually, if they're going to 25 reps, they're not going to be close to failure usually because that's very, very uncomfortable to do that many challenging reps. So I say if you do more than 15 safely with good technique, next time bump it up a touch. Even if you only get 8, 10, that's all right. Work your way back up to 15 and then restart the process. So where people run into issues with resistance training is they make it too complicated, or I find they don't progress it to actually make it challenging. And for most people, I want to find at least one exercise where we have the equipment to handle a load that gets heavier, meaning something that's going to be 20 pounds, 30 pounds. For most people, 50 pounds and above. Because if you want to travel with a checked suitcase, even if it's a wheelie suitcase, you're going to have to lift it somewhere. And usually that's about 50 pounds. So most people are like, oh, 50 pounds, that's a lot. And so I want people to be comfortable with loads that they're going to encounter. And there's a lot of reasons, threw that around, a lot of reasons for that from an injury standpoint as well as a benefit standpoint. And then having a backup plan, things you can do if life goes wrong. Final, I'll kind of breeze through a couple things here, but goals and expectations. Where people go wrong is they're either looking for weight loss changes, which aren't going to happen, or they are unaware of how long exercise takes to make a difference. And so exercise, unfortunately, takes time. Usually the first changes that we see are some improvement in balance, coordination, what's called neuromuscular activation. Our brain learns to fire muscles a little more strongly. And so we often see an increase in strength and endurance in the first couple of weeks, but then that plateaus. And it plateaus for 6, 8, sometimes 12 weeks. And so usually people are 3, 4 weeks in, they are psyched, and then they may have 6, 8, 10, 12 weeks of no visible change in how much they can lift, how fast they can do whatever they're doing. And that's where usually people get discouraged at somewhere around 6 to 8 weeks, maybe 10 weeks, when they're maybe this close to having a breakthrough. But where do we see people give up? Mid-February, if it's a New Year's resolution. And that's, I think, because of some of the physiology, is it takes time. So letting people know that, anticipating that lull at 6 to 8 weeks and making sure you're there to help them get through that. And so SMART goals are a thing, but for some reason in school, I never liked those. So I think of goals that are meaningful, they're achievable, and they're process oriented, meaning what is the process to get there, and can I embrace that in some way that's fun or joyful, or at least just something I can get into a routine with. Let's work on the process and making that the goal rather than the outcome, and let the outcomes come as a result of the process. And then let's reassess and progress. I'll kind of leave with this, is that if you're working with somebody on exercise and they come back to you and say it didn't work, don't make it their fault, make it your fault. You made the program too hard, you made it too complicated, you didn't help them anticipate a barrier, there's something that you missed. If you've done that 5, 6, 7 times, then maybe there's a meeting in the middle. But generally, I find it's the provider, it's me, that didn't quite anticipate something. And I want the patient to know that, so then we can reassess, progress, and I can help them get into a routine that maybe is a little bit better, but I need to collaborate with them to do that. If I'm thinking that, ooh, I messed up somewhere, how can I help this person a little bit better? So that's what I got for you today. I don't know if we have a few minutes for questions, but thank you so much for having me and for all the input throughout the session. Appreciate it.
Brian, I have another question from Aura. It says, how do we start to change the culture?
Oh man, that's another. And
Just a little question.
I mean, my hope is, and I think this is the hope everybody put on the presentation and the speakers is that there's at least some type of ripple effect. And so if you are, I think, Abby and I've talked, people who are in maybe have some type of privilege, if they're in a healthcare environment that they're seeing something happen, maybe it's a little bit easier for us to speak up. Because we haven't had the same stigma or discrimination. But also there's 30 of us here and I don't know how many online. And so if we can tell one person, if we can push back a little bit on one colleague's narrative or one family member's narrative, if we can, help to engage in some conversation. And so I do think research matters. There was $2 million versus $2 billion. But I think, a ripple effect. It says it takes 20 years on average for published science to get into the mainstream. So hopefully we're almost there. Maybe we're past that, but yeah, or I hope I don't have a good answer. Yeah. Cool. Right. Thank you, guys. Yeah, I'm just turning my speaker on so maybe people can hear me. Steve just said we can embrace play, and I think that's something that's challenging for adults is how do we play? And so this isn't ideal for every body shape, size, injury history, but something I've been doing actually is having people just skip, like elementary school skipping. I haven't found a person who doesn't remember how to do it as long as it's safe for them, and everybody ends up smiling afterwards. And so, so if you don't like running, maybe try skipping a little bit.
Okay, we are ready for our final presentation. Before I do that, thank you, Brian. That was a fabulous presentation on exercise. And the final presentation is a panel discussion on the challenges and potential solutions to lifestyle changes from the lived experience perspective of panelists. And leading our panel will be Dr. Michelle May, who you've already met, and Lori Perlmutter, who has spent over 3 decades in healthcare leadership, focusing on population health and social determinants of health. She directed hospital rehabilitation departments, skilled nursing facilities, and quality and population health departments, creating programs for diabetes, cancer, chronic condition care management, and bariatric surgery. Lori has also taught epidemiology and population health as an adjunct professor in the Doctor of Physical Therapy program at Northern Arizona University. And she now serves on the Center for Medicare Services Quality Committee Clinician Group and the Payment Policy and Advocacy Committee of the American Physical Therapy Association to help us assure high quality, equitable care.
Love language, social determinants of health and population health, and I just love it. So I've loved all these discussions and would love to have days to talk about this. But I really wanted Dr. Michelle May is going to be answering, talking a little bit, but I really wanted to introduce also, because you haven't met them, Brandon Leonard and Keanu Reeves. And I'm sorry. Said that to me. It's like Keanu Reeves. Keanu Reeves. Okay, now my head is blanking out. Keanu Fraser. I've never said that before. You said that to me, so I'm gonna blame you for that. But anyway, what? But it's a good person to be like, I guess. So anyway, Keanu, you live in Winslow, correct? And your position is youth.
So I'm the youth wellness manager and our mobile unit coordinator for our hospital.
Okay. And then Brandon lives in Delcon and.
Hi, I'm Brandon. I'm a probation officer for Navajo County. Pretty much.
Okay.
That's all I do right now.
And so what I wanted to let them do is just speak for a little bit about their challenges, because we talked just a lot about general challenges and all that, but they come from areas where there's other types of challenges. There's environmental, there's where they're living, there's access to resources. We talked a lot about food when we were meeting on Zoom, how you get your food and where you do exercise and all that. So I wanted each one of them to talk about their experiences and some of the challenges they've had. So when providers are talking to people, they're thinking about how this person fits into a population. They are somebody in front of us, but they also are part of a population, and they have a variety of social determinants that they're dealing with at the same time. Every person with knee pain is not like every other person with knee pain. So go ahead. I'll let Brandon speak first.
Hi. So some of the barriers that I faced personally, coming from a rural community, was just the availability of, healthy food choices. Coming from a lower socioeconomic, I guess, status, we grew up where, it was just meat and potatoes, whatever's available. They have a thing called, they call it commodity food, but it comes from the USDA. And it's kind of like a food bank, but it's from the government. I'm sure there's a lot of Native Americans that have experience with that. And a lot of it is high in sodium, not really nutritious. It fills the stomach, but it's not something that you can live off of for a long period of time without having side effects like diabetes or high blood pressure. And those are some of the barriers that we face. And as speaking on activity and exercise, some of the barriers, availability, having a facility like the hospital is only open for a certain amount of time. And a lot of people do work 8 to 5, or they work an overnight job. So there's no time for them to get a full night's rest or a full day's rest and then go to the gym to get a good exercise. And I think that's one of the barriers that we see more often. And I know there's programs on the Navajo Reservation, the diabetes special management, and they're open from 8 to 5, and it's very hard to just motivate yourself to get up at an earlier time to get to the next. Sorry. Normally I'm pretty loud, but I'm kind of nervous because first time I'm being part of a panel. So, just the availability of exercise facilities for us on the reservation is it's very, very low for us to get out and do the exercises. Also, if you are on a day off, you have a day off to go to the gym, which is at Delcon Medical Center. You feel like one of the barriers would be, the judgment, the stigma, you're being looked at like you're being judged. Hey, yeah, he's not doing it right. You need to do it this way. And so a lot of people don't go. So if you look at their sign-in sheet, it's kind of small. I don't know what else to say about my personal experience. So I'm going to pass the mic to Keanu here.
So the question is the barriers that I faced growing up, right?
Also, since you do work with youth, if there's anything you can tell us about that.
So from my personal experience growing up on the res, so my name's Keanu Frazier. Ziskatni and Tachitni. I'm from Biclabado, New Mexico. I moved to Arizona about 6 years ago. So originally from New Mexico, went to college in Durango, graduated from there, then came here, worked or lived here in Arizona for 6 years now, and then just finished grad school. So that's just my background and then where I'm from. So Navajo, we have a clan system. The first clan I said is my mom, my dad, my mom's, and the second one's my dad's. But that's where I'm from. So I'm the newish still to the Arizona area. I think I've always told myself for years that I was never going to move to Arizona. It was like one of my states that I had on my list as a number one, and sure enough, but yeah, but I think my personal experience growing up just in a rural area in a community, it's a little different. Like so not different. It's actually pretty the same as Brennan. I know where he grew up. I grew up on New Mexico res, the Navajo res side. And ours was about an hour, 30 minutes from grocery store. But again, I grew up there, so I knew nothing different. There's already a disadvantage, but as a kid, you don't know it and you kind of just go with it. And then to me, I think now as an adult, I always reflect on my childhood just because of my parents. Because again, they worked both. Like my dad was a farmer. He worked 16-hour shifts every day. He was rarely home. He was always at work, got home late, left early. Mom was working too as well, and she was in school. Then when she finished her bachelor's, my dad stopped working, started going to school, finished school. Then my mom went back for her master's. So they kind of like rotated back and forth. So again, I had a different experience growing up, but that didn't come later, probably like around high schoolish. So it's kind of at a young age. I remember like what Brandon was saying, there's commodity foods. So like to this day, like if I can get a hand on commodity foods, usually it's a cheese because it's really good. But just let you guys know. But I remember growing up, like Brendan said, like you get meat in a can, there's chicken in a can, there's pork in a can, and then you're like, all right, you open the can. I remember as a kid, we used to eat it, and you're like, man, how did it make this taste good? And he's, oh, I know, a lot of salted butter. So growing up, I remember that. And I think the one thing, and that was like one of the foods I remember, like that memory. I remember like hanging out with my dad and my brothers. And again, I think it brings into that like commodity. So like for example, commodities like how like in that like Italian style food, like restaurants or families, you go in there, everything's like a commodity. It's off one thing and you pull. So that was like one of the approaches that kind of went into, and I guess in that way in native culture because we didn't have much. And so like growing up, what I remember when I finished school, because I got my bachelor's in exercise science, I remember we would discuss bread. And then I remember from discussing bread in one of my classes, I remember as a kid, we had a loaf of bread at the table all the time, right there. And that's because what I was always told by my uncles, relatives, was that gets us full. Again, we didn't have much. So bread was there. So that was to help us fill the void of whatever we didn't get. So like example, if you had ground beef, it's like 73, what? 73, 23, whatever. It's really fatty. 73 said 27, what do you know, the 80-20 meat. So I remember as a kid, we would get that. And then you cook it. It's like I forgot what they called, but basically you cook the hamburger meat, you put water, you make gravy, then you make it, you put it on the bread. That was one of my favorite meals as a kid. But I mean, that just goes into like, I guess, just seeing that like a representation of growing up from me and Brendan's point of view and just that environment. And then also just going into, we were making what best of what we had. And then I think when I moved to Winslow, I started to experience different part of res. Navajo Nation, right? It's all one big res. We're all intertwined. And then I found out when I moved from where I'm originally from, we really live by the San Juan River. It goes right through us. We have farms and we have all that. So I grew up in summers helping cousins get watermelon, whatever, hay. And then I go to the grocery store or outside the grocery store, we had our flea market, people were selling their produce. So I grew up seeing that. And then I came out here, down to Winslow, the areas, the communities we have, like Dilcon and our service area here. I started noticing, like, oh, wow. So a lot of the vegetables, like there's a thing, it's called sumac. You guys know it? It's called chichen in Navajo. So we make it, it's almost like a pudding in a way. Yeah, it's like cream of wheat in a way, but with sumac. So I grew up having that, and we had it because it was by the mountain. Where I grew up was by a mountain too. But when I came out here, it was something I learned is that they didn't have it. So people were like, "What is this? We don't have this in our area." And then I started to learn like, oh, because I was a biology major as well for a little bit, for like 80 credits. I was a biology major. Then I changed my major to exercise science. But I learned, and I was like, oh, I started to identify like the whole area and seeing what they had and what resources they had and seeing how different it was from where I was from. So that kind of, I got to learn a little bit more and seeing, like, I guess, things I'm grateful for growing up where I was, but also seeing this other point of view and seeing how families in the community and the communities I help serve at our hospital and how we can help them and how I can see a different perspective. But I think that came from growing up from it and just being part of it and just being aware of it. And then also, I was telling Lori earlier, I think one thing I learned from my dad was, as a kid, was always making a weakness a strength. So that's one thing I've been doing, I think, within the past few years now with a lot of, I think, the way I approach things, if it's through school or if it's through working with contractors. Now that I'm more in an administrative role in my work, if I can't leverage, if there's something that's like a barrier, so like say if it's GIPRA, there's a weakness there, but there's also a strength in it. And I found that out, like, for example, working on contracts. So when I work on contracts, that's where that negotiation comes, and it helps me leverage that and also creates a better relationship. So that's one thing that I think that these foundational things I think of from what I learned as a kid, but from my parents, my dad, my nollies, my grandparents, and all of them. So it's kind of going into that, like it brought to what's going on now. And for youth wellness, so I grew up in sports. I grew up wrestling my whole life since I was 3. So I've cauliflower ears on both sides. So like exactly what everyone presented on today, I lived that life. I think I started checking my weight like at 9. I was at Division 3 in wrestling. Started checking weight. I was at 90 pounds. I could tell you my whole life's weight from 9 years old all the way up to about 23. And that's when I started to tell them I started stop because every day from that age of 9, I always checked my weight every morning. And it's just, again, that's wrestling culture. That's part of it. You grow up in it, you learn it. It's your life. And that was my life at the time. And it's grateful. There's a lot of discipline I got from it. And again, my dad was my coach. So there's a lot of things I'm grateful for in that. It helped raise me to be the person I am. But also I saw things that were not good. And the cool part is, as my dad being a coach and father and my mentor, that all the stuff I grew up learning from him as a kid, and that seeing him being a coach now is different. He has a different point of view. And before it wasn't really about winning for him. It was about trying your best. But I think his perspective now changed from wanting the kids to try their best, but to also he wants he wants to grow the sport and the culture. So he's more for the kids enjoying it as a like playing. So my nephew, he's 8. He's second year wrestling. We didn't force him. Me and my brothers all talked about it like when we were like high school. So we're not forcing our kids to wrestle. And so my nephew is born. He decided to join. We don't even coach him. Like I just watch. I'm an uncle. I told my brother, and my brother's the same way. We let him do it. If he lose, he wins. That's fine. But he's loving it, and it's something that like you guys are saying. There's those like you're making an activity a punishment, and that's one of the things we're not doing. And also it's just the weigh-in stuff. That's something we don't want him to do. So like we're like, okay, let's just let this guy go. If he gains weight, that's fine. But then I say he's still going to be active. So like I guess the foundational things as kids, my parents always told us you're either in sports or you're in school. And if you're not in sports, then you got to figure something else. So that's where I did like sports medicine in high school. If I wasn't in sports, I was in sports medicine class in high school. So that's kind of where I went. But yeah, but that's kind of that. And it just went into the role as a youth wellness manager, former role, just recently that would change that. But I kind of brought that perspective as well with contracts, with working with students, with providing more resources out in the community, and just using a community health assessment to help use that as leverage to create those opportunities, but to also identify KPIs as well, key performance indicators.
Michelle, did you want to briefly add anything on your own background that we don't know yet?
No, I think you have a lot of information about me already. I would like to just share something that I started doing with my patients with exercise resistance. So, because I'd love for us to save a lot of time for you to ask questions. But just real quickly, one of the things I say to my patients who say, "Oh, I just saw that I'm supposed to be exercising 5 times a week," why do they keep raising the bar when people are not already doing? It makes no sense. So I started telling people, let's lower the bar. Lower the bar so low that it is irresistible to go over it. And so I tell people, instead of what's the most amount of exercise you can do, what's the least amount of exercise you can do joyfully and consistently? So that's what I'm always working with people. What's the least amount you can do joyfully and consistently? And I always remember this one person I was working with who she struggled and struggled. And I asked her that question. She said, well, I could walk to my parents' house. And I said, okay, tell me more about that. She said, well, they live 2 houses down from me. Like, she was really super embarrassed that her parents lived 2 houses down. She said, I check in on them twice a day, on my way to work and on my way back from work. And I go in my car. So she said, I'm going to start walking there. So she came back the next week and I said, well, how did that go? And she said, you're not going to believe this, but it's actually faster to walk than to drive and park and get out. And she said, by the end of the week, I was walking the long way home. And so giving people permission to start exactly where they are and making it super easy, then they can build on that. So just more of a practical echo of exactly what you said. So exactly.
So I don't want to keep reiterating this, but we had talked about this. If any of you are familiar with the book Kaizen, so Kaizen means small change, and part of my background is process improvement. It actually means good change, but you take it as a very, very small change. And sometimes telling people, well, you have a treadmill, you're not using it, may I suggest you just stand on it for 1 minute? And, just having people look at very small things they can do. And the book is written by a psychologist, and this really means something to me, and it sways into every part of our life. When you tell people what to do, even when you argue with them about their politics, when you start telling them and barking at them, like I used to bark exercises, do these exercises so many times a day, that it actually creates a fight or flight. We want to run away from that because it's a danger. But if we present it, like you said, as people like to solve problems. So if you present it as a challenge, like, how might you? I know it sounds like you want to exercise, but you don't have really the time. How might you work more into your life? Like, have you thought about that? And then it goes into the frontal lobe and they start thinking of ways they can do things. And suddenly she says, it took less time. So you're asking them to solve problems. And the other thing I wanted to mention is, who mentioned ACE scores? Was that you? Or yeah, okay. So does everybody know what that is? Because that's adverse childhood experience. And what is it, like 7? Is there 7 or 10? 10. And what is it? If any one can cause problems in your mortality and morbidity later on in life. But what I've heard is if you have 4, it's pretty significant. That's with everything else. Even if they have a great life going forward, it can affect them in adulthood. And one of the things, I don't like the word resilience, I like the word capacity. Building capacity, like you're doing with the youth and all, can help them address the challenges. And you had ACE scores, not because your parents were bad to you or anything, but just you didn't have food. You were living in places where things were inaccessible. So building that capacity is just wonderful. And then I'll let everyone ask questions. Anybody have any questions for Anna?
Thank both of you guys for sharing the background. That was, really appreciate it. In grad school, I did a bit of work on the Navajo Nation with research on cancer, survival, and exercise. Something we ran into that I didn't always get a clear understanding of at that time was different cultural beliefs about exercise. And so, in the culture I grew up in, my grandmother, I don't think got out of breath a single day in her life, and certainly didn't lift weights. And so just wonder if you have any insight on how, healthcare professionals might approach physical activity and, particularly resistance training, I find can be tricky from an equipment standpoint, as well as just from that's not a thing that I've seen anybody do. Just any thoughts on how healthcare providers might bridge that gap.
So how you can approach that gap? I think when I used to be a fitness tech, when I first started at the hospital, I created because that was one of the challenges, because it was getting people to work out. And the one thing that I found that helped me was I made a workout sheet. And then that workout sheet, I took pictures. So on those pictures, it kind of or well, I made it, but then I made it more cultural relevant. So it all went to house, like what they do at home, like with sheep, if they're doing work in a car, whatever. And it made it more relatable, the workouts. And then from there, I started to add in more like the 90 degrees and like there's those softwares. I didn't have that software, but I did it like all with the paper and then lined it up. So I had my 90 degrees tight. So we were good there. But that's one of the things I did. And it was hard in the beginning because I had to work on my analogies. And the one thing I know, like when I used to help with, when I was a fitness tech at the time, was I remember I had this gentleman, he came in and I used to do like monthly with him. And then he came in monthly, but the one thing I asked, like we were just like he got comfortable and he's like, I like coming here. I was like, why? He's like, because you make it relatable for me. He's like, because he's like, every time I work out, I always wonder why I do this. And he's like, I never understood it. So like one example for analogy I use was like like you know how the car engine has oil, and I told him that you need water, that's your oil for your body. And I said, what happens if you don't have any water or oil in your engine? I said, it dries out, right? I said, what happens to your joints? What happens in the nutrients? Nothing's pushing it through in your engine. And I said, that's what water does. And he's like, oh, okay. And then so I just started picking off from there because he worked on vehicles a lot. So fortunately enough, I had a lot of knowledge in vehicles. I like working on vehicles as well. So that kind of helped there. And then also just I think was being more personable was one thing. I noticed like when I first started, I would see patients coming in, providers sometimes would just read the charts and that's about it. And they just read, oh, this is what was done last. Okay, cool. We'll do this and there. And then I know when I would get them, I was like, okay, let's see what the chart looks like, what we have there. And then after that, I would say, okay, cool. And I just ask them, how's your day? And plus, again, I'm from the area. So I know that this patient didn't come from our community. He probably got referred out or something. And that's one of the things that I've noticed. So like sometimes I'll ask them, where are you from? They're like, oh, I live in Dilcon. I say, oh, cool. Where are you from? See, Navajo, that's cultural. If you ask them where they're from, they're telling you where they live, but that's not where they're from. So if you to ask like Brandon, like if you guys ask me where I live in Winslow. But culturally, if you ask me where I'm from Biclavo, New Mexico. So that's one of the things, those cultural things you got to start to learn and start to understand more. And then you're like, oh, because then they're going to say, what do you mean? They're going to look at you kind of off like, what do you mean where I live? Or like they're going to figure out which one you mean because they're not too sure. So that's one of the different approaches. And then so like and again, me growing up, I've always like done that anyways, just talking to patients or just anyone I meet and it's like, hey, where are you from? And there's like, oh, I'm from here. I was like, where are your clans? And blah, blah, blah. Then they go on and I was like, oh, I'm from, and then fortunately they're originally from New Mexico as well. I was like, oh, cool. Do you know this person? And it's like, oh, I know that guy. I used to work with him. And it just somehow worked out again. And that's kind of one of those approaches. I just ask how their day was and just make small talk. And then they just do all the talking after that. But that was one of the ways I did it was just being analogies into their personal life. And then also that little framework I made, it wasn't just for adults, it was for kids as well. And it was targeted for our youth population when I made that workout sheet. And one thing it was, we were needing to make it more cultural appropriate. So you know how like you can go to like the University of Michigan, you can get those printouts that shows workouts and all. And there's not any brown people. So I used my coworker. I used him, so that's why I made my own. And then I put descriptions in, and then I typed it all out, put a little bit of Navajo words in it or whatever I thought. But yeah, I typed it out, but I made it to where it was more accessible and understandable. So it's like I'm talking. So that was one of the things that approaches that I did to help with it. And it also helped them open up more and it made them excited to come. And the unfortunate thing was COVID started. Then after that, I was like, all right. And then because I started to build more of a rapport with more patients. So I started getting more like patients wanting to come in, check in monthly. And now I started to see get my little patients that would come in, start to come in more and more. And then after a while, they would just call me. He's like, hey, how you doing? He's like, hey, I just want to make sure. They just wanted to check in on me, see how I was doing, and wanted to make sure if we're still on for whenever we're going to meet again. And then you just go from there and then you just talk. And then after that, you just ask how they're doing. That's kind of how I approached it. But getting to know them beyond the clinic is one of the things and understanding where they're from. And I think when I moved to Winslow, my mom, she has her master's in public health. and she did a lot of community work. And I remember as a kid, I can tell you this perspective as well. As a kid in high school and in junior high, we used to hate going into hospitals because we would go there and the doctors knew nothing about the community. They never got out of the community. They stayed in the clinic. So they would try to tell us all this stuff. And we was like, we don't see you. And like at school, we was like, you don't see you here. And I took that mindset from when I was a kid to somehow ended up in healthcare. Uh, ended up in healthcare, and I took that mindset. I remember as a kid and brought that. And then, so when I first came to Winslow, I think the first week I moved here to the area, to our reserve district part of the res, I went to every eight of the unit services we went. I went to their gas stations. I went to their communities. I went to see what snacks they had, and I also went to see which ones had hot pickles, because culturally, that's one of the things for Navajos and natives is pickles. So I was like, all right, I got to find my hot pickle spots. And I wanted to get to know this area. I got to get to know the chapters, and I got to get to know this. So I did that. My first week, I went everywhere in the community. And then I started to figure out. And then when I would see patients and there's like, where are you from? Then I had to do my whole spiel where I was from, like going from there. And then after that, there's like, have you been here? And I was like, I never heard of this place, but I went there the other day. And then they started inviting me to like cookouts and all that stuff. But yeah, so it's getting to know that. That was one thing that helped me. Because I could have just stayed in Winslow, just gone to the hospital and gone there. And then, but I took that initiative to go get to know where they're from and get to know their environment. And then now when I do speak with patients, I mean, I'm not doing clinical as much, but when I do project plans or create anything for a budget or planning something for events, I know that environment well in those communities. So I know how to approach it. And I know who their key stakeholders are in that community. So I know how to work with them and who are the local leaders. And one thing I've been changing is their leaders, not just there's not one leader, their leader at home. That's one thing I've been talking to my mom about, I think the past like 2 months, is like trying to change that mindset to telling people that, or even staff that I work with, that you're not, if you don't feel like you're a leader at work, you're a leader at home. Because if you have kids, if you have family, everyone looks up to you. Someone looks up to you. So I kind of get that into some of the team members that I used to supervise now. I think that perspective helped me as a leader and helped me, I guess, just adapt with the team and learn also how to coach people and how to, just improve themselves to hopefully be better than me. That's kind of one thing I got from my dad, and it's kind of stuck with me now.
So, okay, because I was going to ask if you had that experience also with when people spoke to you, like your personal, when you were dealing with healthcare providers.
So going to I'm sorry, I forgot your name. Ryan. His question on cancer patients and exercise resistance training. Personally, my son, he battled leukemia twice, and he just went through remission. And a lot of the times, the difficulties in responding to exercise and responding to resistance training, you have to take into consideration like the medications they're taking. A lot of it, like the steroids, it makes them tired. They want to sleep. They don't want to move too much. The nausea. And then you have to think about cultural sensitivity. A lot of Navajo families, they're reserved. They don't like to talk about things that are going on in their lives. We were the exception, my family, because we got out there and we advocated for childhood cancer. And that's all I got on that.
He asked about whether there were attitudes about exercise or different perspectives about exercise in your community. Did you notice that?
I did not know. The attitudes towards exercise in my community, there's not a whole lot of that going on. A lot of it goes through the IHS there, and they'll go to like Just Move It events, which he helped coordinate, and and they would go for the free stuff, like the incentives. That's what they would go for, because Navajos like free stuff. We like free stuff.
I guess to answer that question too now for the I think that's one of the not tougher things, but it'd be more into playing into what's the more more relevant of active sport. So like now we'll go down into this area, it's like basketball, cross country. And those are one of the big ones on not just here, but on the res is that. So that's like kind of something to play into. I know when we plan like school events or when I was helping out, when I was managing youth wellness team, that was one of the things we kind of steered into the basketball to help. It's kind of like almost like, you know, in like harm reduction training, they say there's a problem, like how can you like help that problem? So it's kind of like just kind of leaned into that. It's like, okay, well, we're going to do basketball because I know we'll get numbers, but we'll get more kids out there. And that their cousins, they're going to invite their cousins to come. So, and it's like getting out more events. And I guess going into that would be like our strategic plan for organization. Because we were on the part of the team for creating our community health assessment. And now we are using that strategic plan or that community health assessment, or we got the top 10 priorities. And one of them was adding more community events out in the community for just everybody in general. So that's one of the things we're doing. So I guess in a way, think about now, it's more of a systematic approach rather than like a community individual. But if we're able to do it a systematic approach way, then we can start getting more impactful, but also more sustainability through that way, because there's policy and there's also going to be organization mind driven towards that. So that's one of the things we're doing now. And it's also just making sure that we're able to just have the staff for that, you know, just like making sure that everyone's available to these events, because parents, they get off work after 5, really 6:30, honestly. They get home, they have to get the kids ready, they have to get ready, change, and then get to the event. So I think it's one of the things going past 5 o'clock or even going before 5 o'clock. So it goes back and forth.
Anybody else have? I do have, oh, go ahead.
I was just going to ask, you know, a lot of what you all have discussed is it's all about success. We can call it competence. So whether you're in the clinic working with folks, finding those exercises that they can be successful to do, and success breeds success, right? We haven't heard as much about like the, you know, nutrition, and consult with an RD is never prescribed. As far as I never hear about that being prescribed for folks, whether it's, you know, for pre-surgery or just in general, right? And this goes regardless of how big our bodies are, right? So I'm just wondering if you all have examples of more success. I mean, Kiana, you shared some, which was fantastic, but examples of successes, whether you personally or whether you've seen that with clients, where you've had to adjust based on learning from what those folks have, where they're coming from, their communities. What's like any stories about successes that are good examples of how maybe providers can maybe learn from that to help more people have more success early on, as those little battles, those little wins. I don't know if that makes any sense or not, but I'd love to hear more success stories.
I understood your question. My son, who I just spoke on earlier, at the clinic there in Delcon, they have a thing called Victory Clinic, and it's for children who are at risk of diabetes. My son's 10 years old. He was borderline type 2 diabetic. And so we started going to that Victory Clinic, and we lowered his A1C from, I think, 5.8 to 5.1. So that's a very good victory story. They have victory group sessions where we go to the group session in the evening, and they do like a cooking demonstration with alternative ingredients, as opposed to like your normal traditional Navajo diet, which is basically like meat and potatoes and grease and salt.
Modern.
Okay, modern habitual cooking. So they introduced alternative methods to enjoying the same type of foods with alternative ingredients, healthier choice ingredients, and taking that and introducing it to our household has helped the whole family in general, and not just our son. So good stuff there.
One I can add, or just go on a little bit with Brendan with our victory program that we do. So with that program, it's coordinated with our nutrition department. So our nutrition department, what they do is they'll do a lot of that, but also they provide they'll do food demos as well in the community. So it's just not at the victory level, at the kids, our youth wellness clinic level. It's going to be also at adults. So they'll do those as well. And then if they we have community events, they'll go out to the community events as well, and they'll have the food prepped already, and they'll take them out and start handing them out. But another, I guess, in a way, success that I feel like is on food distributions. So currently now, that's one of the things I've been working on this past, for a while now, but one of the things is getting a sustainable food distribution out where we're at. Because we got one in Winslow, which is sustainable. That one we're doing with FCCC, Flagstaff, up here. And we have another one that we just started 3 weeks ago. That one as well we're working on, but that one's a little harder. You're more rural. You don't have as much volunteers or staff to get out there. So that's one of the challenges, but we're getting that out there now, and we're trying to get that customizable to where we can start pick and choosing the items we get. And if it's all produce, and we can start making a menu strictly for that. So there's a lot of planning we're going into that, and just making sure that that whole process is sustainable. But also, so when we do plan these victory or the food distribution days are on our Thursdays. So we know our clinic flow and our busy days on our clinic. And so clinic's going to be our women's health clinic, our prenatal clinic is going to be on Thursdays. So that's why we put it on Thursdays. And Thursdays is also as well one of our DM clinic days. So those two clinics are big clinics. Those patients come, but when they do come in, they're able to get that food box as well to take home. So we figure out those hot days for our clinics, and then that's how we plan around a lot of it. And that's part of one of the things that helps us get success, because those are full clinic days, but also we get the patients, they're able to get their food. Some of them drive an hour, 2 hours to us. So they're able to get it. And also when we do plan our food distributions, we plan it on the off weeks of payday, because they buy all their groceries. Next week they have nothing. So we plan it on that. So we strategically plan the days for the food distribution. There's just not a day we chose. There's a specific time we chose. So everything's thoroughly detailed on what we do and how we plan those food distributions. So that's how we try to go back and forth. But yeah, so that's one of the successes right now. And it's going to eventually get bigger, because we have it at Winslow, our Winslow clinic. We're going to try to get it more sustainable, our Dilcon clinic. And then also I want to start taking it out more into other communities as well, not just keeping it there to where they come to us, but where we go to them. And I'm also the mobile unit coordinator. So being mobile is my job. So making everything accessible, taking all clinics anywhere as I can out in the community with our mobile van that we have rigged for clinical services. So there's a lot of things. I was like car seats, for example. Our mobile van is a clinical room setting. So we do more car seat distributions out in the community. So we did it 2 weeks ago. We're at one of our further communities about 2 hours away, and we did a car seat distribution out there, and we gave about 20 in 4 hours. And so that's one of the other success I could say that other than clinical, but that I see that's been really successful, and also seeing how impactful it is, because car seats are expensive. And believe it or not, there's a high mortality rate in the kids, no car seats. So that's one of the goals I've had when I first started planning that project, and how they take it out there to make it more accessible, because before they just had to come to Winslow. And so that means families drove all the way from where they ever were all the way to Winslow with no car seat. So that's one of the things we were able to provide a safer option, and taking it to them, and just basically being more accessible, just like we want to provide accessible care.
A mobile van is an understatement. That thing is an RV.
Want to say something kind of a total riff off of this. And this is, earlier you talked about all or nothing thinking. This is really, really common in a lot of the people who are struggling with food. They're either on their diet, off their diet, on their exercise program, off. And one of the things I've done is I've moved away from using the word success, because the opposite of success is failure. So I'm looking for progress. I'm always looking for that incremental little tiny step. So it makes sense because those sound like amazing, successful programs. But when I'm working with individuals, I'm not looking for success.
So I want to add on that because when we started the bariatric program here, people came to me for the exercise portion. And the problem is when you have that surgery, sometimes you hit a lot of plateaus and they would feel very unsuccessful. And so we would talk about them finding ways to reward themselves for process and process. So you exercised, for whatever activity you decided to do, you did it for a week or two. How are you going to reward yourself? And we even came up with different rewards. Go find a magazine you wouldn't normally, go walk with a friend, just, tried to keep it away from food rewards. But just don't think about, because they would always be like, well, I didn't lose weight this week. And I said, how about you got up and walked to your parents' house and walked back, or you took your dog out two times a day? Reward yourself for that, for doing the things you have control over. So, yeah.
Are there any more questions?
I think I just have one thing, where I think it's so essential for a lot of the programs you all are really a huge part of, because I think that, when we're thinking about exercise or strength or things like that, it's been something that has been part of a leisure class, really since kind of starting like the 30s and 40s. And so now it's seen as something, that's an extra thing. And we've made it into an extra thing again with the clothes, with the gyms, with the equipment. And we can't do anything extra unless our basic needs are met. And this, not even basic needs, but really important needs, right? Of like, I need to be able to safely get my kid from point A to point B. I need to know that I have food on the table. And so I think that's someone's coming even to ask, or if someone's even trying to intervene in a strength perspective, it's like, I think that's where that interdisciplinary team and like these community programs are so essential, because people can't do that extra thing, even from a nervous system level, if we're not assisting there. So more of a statement, but really good job. Way to go.
I guess for Dr. May, do you find, I'm sure you've done this presentation a lot, but does it work just cross-culturally, or do you have to make tweaks for mindful eating exercises, or how does that work when you travel with the same presentation?
That's a great question. So that's one of the things I love about mindful eating, is that it's not dependent on eating a certain type of food or knowing carb content or logging things up. It's very much an internal process. How people process things internally is going to be very different from culture to culture. I did have the privilege of giving the talk in Washington on a reservation for a community event. And just as you were talking about, it was so important to have conversations with community members and have them be part of the planning process and contribute their thoughts. But they were so relieved that some white chick didn't show up and tell them to eat low-fat foods and blah, blah, because that's the kind of thing, that's very alienating. And again, I'm don't have that experience, so I wouldn't assume that I'm the right person to do that. But given the invitation, I think it's important to at least, be part of the conversation first. So, but it's a very flexible approach. I will say it's not dependent on some of the things a lot of other dietary approaches are dependent on.
Any more questions?
I guess just to follow up with that, with Brandon and Keanu, is this something mindful eating in practice, and then the resistance training? I know from a wrestling and sports perspective, it's logical, but is this something that the Navajo community would be receptive to hear?
With the reception, I think that it could be, given the cultural approach, with the mindful eating. I participated back there, and I didn't even finish my food. I was stuffed, and that doesn't happen often, where you sit down, you slow down. and you take the time to, ground yourself to what's in front of you as opposed to being distracted. That's one of the practices that we took from the Victory Clinic as a family is we don't allow electronics at the table. The TV goes off. We sit at the table as a family and, we talk about our day. We interact with one another. We go around the table one by one, telling each other, like, how was your day? What'd you do? What was the best part of your day? What was one thing that you had difficulty with today? Who got in trouble at school? Who did you play with at school to make sure that they're not playing with the people that got in trouble? And asking them their favorite part of the day, like, what was your favorite part of the day? And that was how we usually end the conversation. And after that, we just, have a movie night. But in regards to resistance training and any type of healthy activity, I can't speak on that.
I think so with the mindfulness. It can be, but I think right now, for most, I would assume right now that they would more go into mindfulness, going into wellness, because that's kind of where it's kind of like social media wise, they kind of go in like mindfulness as that is like kind of being categorized as wellness, health and wellness, but not really yet into eating. But I know that is a subject. I know when I was in my undergrad that we talked about was mindfulness a lot. We had a final exam on mindfulness. But yeah, I think it can be. It's just changing that from more of a physical aspect to more of like a healthy habit in eating. That's one of the things I think how just shifting that, not shifting it, but just like approaching it differently is one thing. But it can be. There's a lot of things I've been told I can't do, so I'm pretty sure it can be done. So yeah, that's where I think though, but it should be, it can be. You just got to approach it, and I've never really thought of going into mindful eating, in the way like kind of how you broke it down for us today. I guess the way I could think of mindful eating, like if we ate growing up, was my dad would say if we go to buffet, you have to drink 2 glasses of water before you can go get another plate. So we got our first plate, 2 glasses of water, we didn't even get a second plate. So that was one of the things. But yeah, so I think just shifting that mindfulness.
I love actually what both of you said, because we broke it down here to be able, as you know, to see the process. But really, this is something that can happen organically in a family with, talking about our food, talking about our day, not allowing electronics at the table. This is something that, I think can help all of us connect better. And then I have a question for you. How's your son doing?
He is in remission.
Yay. Awesome. Fantastic.
Is this on? It just came to mind, like even just having a brief handout of like how do you eat mindfully and putting it in the boxes, in the food boxes, right? And then if folks want to look at it, they can and want to try it, or even just making suggestions like turning off the television while eating. But yeah, it is interesting how little suggestions could really go a long way.
Or better yet, asking questions. How does having an electronic in front of you distract you when you eat? And then does that lead to ideas about what to do?
More questions?
Cool.
Thank you.
Thank you for having us.
Hey, thank you all very much. How about another round of applause for our panelists and all of our speakers today? This was a great day. I appreciate all of the presentations and especially the planning team's work. My final thoughts as we wrap this up is, we always talk about physical activity, the pill not taken, right? And rarely prescribed. Same thing with nutrition. There are so many barriers that we saw and that we have to acknowledge folks have whenever we have it, whether we're talking surgery or forget surgery, just life in general. And we've been looking for that solution. We're talking about, adopting healthy living, right? And we don't have an answer to that. It's just something we're going to continue to pursue. But all of these things, and especially being considerate of folks that are in larger bodies, especially how do we make sure we're providing opportunities that are fair for all people. So anyhow, once again, thank you all for the folks that presented today. And yeah, thanks for doing the survey. And we hopefully send you off safely home, travel safely, and enjoy the rest of the weekend. All right.
We probably have some extra food out there.
Oh, yeah. I'm gonna pass it over to Mike.
That's exactly what I was going to say. Please help yourself to as much food as you need to take. But also, this workshop was recorded just like our previous 4 workshops, and I will be sending out a link. Give me a week because I have to edit the video, but that includes all of the workshops from this year, including today, as well as our first BMI workshop, which I know Abby mentioned, but that one's worth a watch. We post everything online, and that by far has the most views on our CHER YouTube channel. And so it's a breakdown of kind of what we talked today, just in a lot more depth beyond BMI. But yeah, give me a week and I will send that out via email to you all. That way you can review this, you can share it. But these workshops are a great public resource that we provide, and we need to get this information out to the community. And with your help, I think we can do that. But thank you all so much for coming, and safe travels back home.